loving so much to do with women's health. And I'm glad that you talked about the technical inefficiency in maternal health, which you gave a 50%. Indeed, this is visible, but I want you to highlight to us which level did you look at? Was it the community level? Was it the coordination, emergency coordination? Was it from the level 1, 2, 3, and 4? And where is the most level that is mostly affected, so that we can see how we can work on that? Number 2 is the weak referral pathways, the same. Is the pathway the community to the health facility, or is from level 3, 4 to the referral where we have the problem? And when you talk about the underutilization of the health facility, where is the problem? Then just to follow up on the same point is that you said that the study found out that it was managerial inefficiency. How would you define a manager at this level? Is the same managerial level the same in all the health level facilities? And lastly, would you kindly explain to us or recommend what you mean by efficiency dividend, which will be my take-home message today? Thank you.
Thank you so much, Dr. Doris. Kindly go ahead, Tom. Thank you.
Dr. Doris, thank you so much. Very nice and very, 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 very good questions. And I'll start with the last one. So when I mentioned the efficiency dividend, so the method of data and development analysis is really, it just shows we are looking at who is doing the best. So you're looking at a pack of counties, which is 47 counties, and you're comparing with peers. So we're saying, where are they, given the resources that a county has, given the output it's producing, then we get those that are at the frontier, based on adjusting for resources and the outcome that we're getting, and then being able to measure others based on that. So that's how we calculate the efficiency. And within this, we're able to look at it in terms of, we're able to decompose that efficiency measure to what is due to the managerial aspect of it, and managerial is not necessarily you can actually call it organizational. It's how the systems are organized. It's how the services are organized so that they are able to reach the population that we need. It's just like more like an engineering concept. And then the scale part of it is really the size, because there are certain levels where you have a size that additional resources don't necessarily add any value, or the size of the scale of the program is so small that it's not able to reach the population that effectively as needed. So by measuring that gap, that is when we say that if we're able to bridge that gap by doing what the best of the pack is doing, then that unlocks that efficiency dividend. In terms of the level where this was done, so we looked at the data that we have, looked at the county holistically. So we didn't go into the community level, into the like level 3 or level 4 or whichever levels of the healthcare system. We looked at the entire county as a unit and said, let's look at what's happening in terms of maternal mortality in this county. Let's look at the resources that they have, and let's look at the resources that have been put into the county, and then and also then looking at the human resources that they have, and then accounting for that, we're able to say, well, there is some of the things that we can extrapolate from there is that given the lack of performance in some places, the drivers for that could be this and this and this. The things that we've said could be referral networks, which are known that, if you don't get, in obstetric care, if you don't have an effective referral network, then there's a problem there. If you're not having better utilization of services, then you're likely to have a draw on efficiency based on that. So those are things that we are postulating in terms of the potential drivers of the lack of performance. And lastly, one of the things I want to emphasize is that the big limitation we have in this study is that we are looking at resources for 2022, but also looking at the outcomes in 2022. So we can also say that one of the big limitation we have is that we are looking at resources which are from 2022, but those could be affecting outcomes which could be coming later on. So those are some of the limitations, but we recognize those limitations in our analysis. I don't know whether I've answered your question, Doris.
Yes, you have. Yes, you have. Sorry, Tom, I think that was such a comprehensive response, and I think I can see Dr. Doris smiling. I think she's very okay with your response. Thank you so much, Dr. Choki. We still have some time. Do we have any other questions for Tom? And Tom, just coming from me, I think I was following through your presentation, and if I may probably just pose a question on what would you say are the lessons from the relatively strong immunization performance that can be applied then to maternal survival and child survival specifically, because I think from your findings, you really then projected some statistics that clearly showed in regards to immunization performance, we are more or less not doing so badly off in terms of technical efficiency. I don't know, what lessons can we draw from immunization performance, Tom?
Thank you, Dr. Arthur. The main thing that we can draw from there really is, if you remember, immunization program was organized through KEPI, this Kenya Expanded Immunization Program, and it's really one of the things that when I was working in the Kenyan health system, I remember there was a lot of emphasis of communication. There was a lot of emphasis on organizing, the cold chain and all the services that are needed to ensure that those immunization services are effectively delivered. There was child immunization days. There was social. There was a lot of activations that really got the uptake of immunization services. I remember they were even going to schools and all these things. So when you look at that, what that did is, over time, there is a critical cadre. There's a very well-trained workforce within the Kenyan health system that now has gone into the county level, that knows how to organize the immunization services, knows how to deliver these services, even to the last mile. And that's why we are seeing all these gains and in terms of efficiency. Unfortunately, the maternal obstetric care and gynecological care, or rather mainly obstetric care, is a complex service. And there is a likelihood that we do not have that depth of a skilled personnel to organize and to really do this at every county. And some of these drawbacks could be something that we can be able to start organizing things like peer-to-peer learning, places where the counties which are doing well, is there a way that we can be able to learn from one another, so that there is a way of making sure that the services are improving across the entire country. Back to you, Dr. Arthur.
Thank you, Dr. Choki. I think it's clear. A key lesson is drawn from a strengthened healthcare workforce, and I think you mentioned peer-to-peer learning. So thank you so much, Dr. Tom. I don't see any hands, and my guess is that we do have Dr. Tunui. Doc, kindly, if you could just.
Thank you, Tom, for the presentation. I think that was very insightful. I just wanted to talk about the collaboration that we had, especially involving the young students. One, I think I wanted to mention that Delany and Naomi, Delany is an engineer, and he's very technical in collecting this data. Naomi is in finance, so this really brought in various expertise, and I'd really wanted to talk about that because then we were talking about the collaborative nature of engaging various disciplines in having this kind of study happen. Thank you.
Just to add on that, thanks, Dr. Tunoi, for that comment. And really, I think that was the backbone of this research. Getting those two young people who have different expertise. You can see the engineering, data and development analysis that I presented. The main methodological framework of this is really an engineering method. It's an engineering method for productivity and efficiency measuring in the production systems. And finance is, as you can see, is a very critical aspect of, because you are measuring the inputs, and they were very critical in doing that. And I certainly think that there is an opportunity for cross collaboration, not only getting this to be only a public health consideration, but getting people from different disciplines and sharing how we can monitor these efficiency and how we can measure these. That can be very critical in improving our health systems, but also our research, so that we can rigorously measure what works and what doesn't work as we move the frontier. So I think counties do have an opportunity, given that Kenya is a large country. There's a huge opportunity for this kind of collaborative research, where you get different disciplines involved and working very, very closely towards finding solutions. So really want to recognize the contribution of the Dr. Tunoi as the mentor for those young people. And those young people from Kabarak University did an amazing job, and that's why I'm so happy to be part and parcel of this presentation.
Thank you so much, Tom. I think, Tom, we've thrown a whole myriad of questions at you, and thank you for your brilliant, and thank you for your responses. So I think, Tom, thank you. I think we'd end our QA session here. Once again, ladies and gentlemen, that was Dr. Tom Achoki on scale and technical efficiency in health service production with a focus on Kenya. And this was a situation analysis across different counties in Kenya. And I think one of the takeaway from us is basically how can we pull together efforts, leveraging on the different health system blocks to ensure then that we are able to unlock the efficiency dividend. So thank you so much, Dr. Tom Achoki. I think we'll let you off, but if you could still stay with us for the remaining part of the session. I'd like now to just switch gears because of time. Thank you. Thank you, Tom. Thank you, Dr. Achoki. Round of applause for Dr. Achoki. I think he can still hear the claps. Thank you. Thank you, Mercy. Yes, so just moving very quickly because of time, our intention is to have our tea break. Before then, we have some of our guests who are joining us, and we'll have then the main plenary session officially starting off. So I'd like to bring, based on our program, I'd like to bring Brian Demesi from the Ministry of Health, specifically the Department of Child Health. He was to give his presentation, but because of time, we'll just allow Brian a few minutes to make some remarks regarding what he was to present on, but then we'll still project. Okay. Yeah, thank you.
Thank you. Okay. Good morning, everyone. My name is Brian Demesi. I'm standing in for the division of RAMCA, that is on the Child Health and Newborn section. And as I'm standing here, I'm also a master's student under the Clinical Medicine Department. And it was just a brief dissemination in terms of achieve, what we've been able to achieve on the ministry section and also on the county government section. So we have a training package that is an integrated, comprehensive, and essential newborn care training package. Now this is just to focus on the small and the sick newborns. That is, as you understand, Kenya is a low resource setting country. So we'll just look at a small brief on the outline, maybe the guidelines, where we've come from as a country, and what are the implementation process that was been able to achieve us that we have been able to do the trainings, the comprehensive trainings. And also in terms of the post-training mentorship, maybe those are the things, key things that we can focus on, and we are focusing on the comprehensive and also essential. So just as a country, I think we had seen the previous data, and in terms of how our mortalities correlate. As you can be able to see from this is that from around 2008 to 2009, we had a significant improvement in terms of reductions of our mortality. But now, at around 2000, from around 2014 up to 2022, there's only have been a 1% drop in regards to the mortality, especially on the neonates. So we are targeting by the SDGs goal that by the year 2030, we should be able to achieve as a country 12 per 1,000 live births in the neonates. So by 2022, the recent KHIS that was able to release the data is to inform that we were at 21. We have a very short gap period to be able to make sure that we have been able to achieve that 2030. And so this training package came from that information. We were focusing on the 4 main killers that actually were killing our newborns, and it's prematurity, birth asphyxia, neonatal sepsis, and all the complications that usually result from hypothermia. So there was an assessment that was done on 75 hospitals within the country, and it was noted that for most of the facilities, it was mainly because of a poor quality, again, skills gap that were noted, and again, all the things that are required within the facilities, whether we're talking about equipment, human resource, it was noted that we were lacking. So this is where the training package came in. And the training package focused on doing developing two training packages. That is essentials for the levels 2 and 3. And then when you're progressing towards the advanced care, that is the level 4 hospitals going upwards, we had developed a comprehensive newborn care package for them. How the training implementation was done is just a group of, we have a group of consultants, that's the neonatologists, pediatricians, nurses, and it was structured in a 1-week training so that you can be able to do a pre and post test. We do lectures and plus all the videos that usually that are evidence-based, and also doing a facility visit. So this is just one of the sections, and we have our lead neonatologist from MTRH, that is Dr. Audrey, showing a group on how we are how to do resuscitation. That's just an example. And then usually we go to the hospitals, and this was in Chuka. We train the healthcare workers on how to be able to apply the skills that were learned within the hospitals. So a total of over 574, and still counting as we speak, that we still continue with the training. And even up to Mandera, we have been able to train. We noticed that just focusing on the pediatricians and the nurses cannot be, we cannot say that we'll be able to have to cover all of the neonates. So for that one, we also noticed that the anesthetists are really key when you're talking for those babies who are born via CS. So we also involved the anesthetists plus the obstetricians to be part of the training. Now for the post-training, now that we have been able to do that trainings all over across, it has been noted that funding has actually dwindled, and as you're all aware. So the main thing is that after the training, what needs to be done? So equipments were procured all across the hospitals. Whether you're talking about the CPAP machine, caffeine citrus was subsidized. It used to be a little bit expensive, but now, right now, through the ministry, it has been subsidized. And then we have developed skills lab all across our level 4s, 5, and hospitals. There are skills lab so that we can enable these healthcare workers to continue practicing even though they are still in the hospitals. Now we are focusing on mentorship. Trainings are now not quite available because of issues of funding. So now it's more of a facility-based kind of mentorship. And for this, because we are building resilience in our health systems, the pre-service curriculum review, whether talking about the Nursing Council and the COC, they have been able to review their curriculum so that we're using evidence that have been from the national guidelines when these students are being trained. They start from pre-service before coming into the system. This is just an image just to show of distribution of caffeine and the value CPAP. So currently the country embraced the value CPAP because it's a little bit less expensive and it doesn't require electricity. So in conclusion, so an integrated training package targeting all levels of newborns. That is, we're targeting multidisciplinary approach to provide coordinated care so that we can improve the newborn survival. You can all agree with me. There has been more of emphasis on the maternal sections. And most of the time we used to forget that these mothers are actually attend ANC for this 9 months to have a baby. So also newborns need to survive, and that was the main thing that's why these packages were introduced. And then for this need to incorporate these trainings, even though that we are doing it for the healthcare workers, we still have students who are coming into the system. So our curriculum should be based on what the current practice are there, so that even if we are developing those skills lab in the facilities, can it also be imitated to our universities, our institutions, so that also the students can start practicing while they're still doing the academics. So my acknowledgement to the ministry, our county governments, and in the spirit of awareness, we are saying that every woman, every newborn, everywhere. That is the main key that we are targeting. So thank you for this few moments.
Thank you so much, Demisi, Brian. Thank you so much, Brian. And Brian, I probably would like to, since you're here, yes, can just as well do the QA from there. But then let's just, if we can just allow Brian to respond to a few questions you might have. So from our members from the audience, do you have questions? I can take hands. Even as you're waiting questions from the audience, Brian, I just wanted to find out from you, what investments basically are needed, especially to make newborn units more resilient and equitable, keeping to our conference theme on building resilient health systems.
So the investments that are required is that, first of all, the good thing about this package, it has been formulated in such a way that we have standards that we are able to provide in each and every level of care. So when you're talking about those health centers, yes, they are conducting their delivery, but are they able to provide essential newborn care? That is the basic bare minimum that you can be able to provide for those newborns. So those levels have been established for each and every level of the facilities that are within our country. So the other thing that is really required is that even when you're talking about an advanced care and what do you call it, and comprehensive care for those newborns, the level 4 hospitals up to going upwards needs to be able to have these equipments that have been placed. So it also calls for our county governments to be able to ask for more human resource, because right now, as we all know, that health has been devolved. So our county governments, we are trying to re-emphasize on the need to have more specialists, again, have more healthcare workers who will be posted to those newborn units. That is just mainly on what needs to be done for within our hospitals, but we're still hoping that with more emphasis on the newborns, especially on this awareness, when we are targeting our RRIs, is that we might be able to do those small, usually say low-cost methods that can be able to have a large impact for our newborns. At the end of the day, we are just hoping that we can also embrace and be able to have newborn champions all over across. Sawa. Thank you.
Thank you, Brian, for your response. And you're not going to let you off. It's only courteous of us to provide a seat for you because we're hoping to get more questions from the audience. Kindly, colleagues, if we have questions for Brian. Brian, kindly have a seat. Yep. Mm-hmm. Mm-hmm. Great. So what we are going to do, I know we are still warming up for the day, but Brian and myself, we are going to sit here and wait for questions. Yeah, you're going to sit here. Yeah. Oh, there's someone who's raised their hands. If you can get the mic to them. Oh, right there. Second last row. Oh, okay. There's a question. Thank you.
Okay, thanks so much, Brian, for that excellent presentation. And my name is Josephine Wambani, and my question is in terms of the criteria used in the recruitment of the healthcare workers. I've seen you have included all the, I'll say, the most essential individuals that is in the healthcare platform. And my concern is in terms of the neonatal deaths. It's more of like you are looking at babies. I'm not so sure whether you captured stillbirths. Also, it's something that captures children. I'm not so sure why maybe you didn't include their mothers, because this is something that is very important when it comes to how these people will actually be uptaking the services. And the last thing maybe I wanted to include is what really informed you to just train the healthcare workers? It being their mothers could have played a critical role in terms of uptaking these services, and also in terms of helping it, like people being able to understand what you're actually doing. Finally, when you're doing research, it is important that we have an aspect whereby there is inclusivity in terms of the people we include in the packages that we are having or that we are carrying out. How did you do that specifically for this training? Because I can only see the healthcare workers. I've not seen an aspect of stakeholder engagement. I've not seen a specific place whereby you have included the minority people in the community who might actually play a role when it comes to the uptake of these services. Thank you.
So in 1 minute, because I think we are short on time. So yes, so 30 seconds. Okay, so in 30 seconds. So I'll just address it in inclusion criteria. Initially, when we started, we had only focused on the newborn providers. But again, we came to realize that anesthetist is important, that obstetrician is important. It continues to the whole aspect of even that clinician at the outpatient who's seeing those babies being referred to them, they are quite important. So by now, trainings are not able to be done for all healthcare workers, but there are mentorships that are being run within the country right as we speak. So planning on mentorship, we'll be able to mentor all healthcare workers on what we've been able to, whatever the package that we have created. So remember, training is not the only thing. There's mentorship also that will continue. Thank you.
Thank you so much, Brian, and apologies. I know we've rushed you through. We had a couple of questions. Kindly let's take the questions in our breakouts later in the afternoon. We still have Brian around. He's going to be making his presentation in one of our breakouts. So thank you so much, Brian. And let's round of applause for Brian Demisi. Thank you so much. Thank you. So I'm going to hand over the program now to Dr. Charles Walekwa, and who will lead us to the next. Michael Walekwa.
Dr. Ava is telling me Charles was his favorite lecturer. And we have some sort of resemblance. Well, but I'm not old enough to have taught you. We are ready to start the official opening ceremony for this plenary. Thank you so much, Dr. Ngetich, for leading out that session. The team that is setting up is the Kabarak University Chapel Choir, together with the Woodwind Brass Band from the School of Music and Media. Our guests are already here, and they will be getting into the hall in just a couple of minutes. Two, I request that when they make their way into the hall, we kindly rise to give them a warm welcome. As soon as they have settled in their spaces, we shall sing through the anthems, and we shall do this starting with the Kenya National Anthem, the East African Community Anthem, and finish with the Kabarak University Anthem. Thereafter, we shall do the devotional thought and opening prayer, and the program will continue to flow. I promise that this is going to be a very interesting day for us, because we have lots and lots of research outputs that are going to be disseminated with us. Right. This conference is also streaming live on YouTube. It's streaming live on Facebook. We also have it as a hybrid conference. So we have some people who are actually following us online. We shall be engaging interactively with them. We may now rise. And now the anthems, starting with the Kenya National Anthem, ESC and Kabarak. now be seated. Vice-Chancellor, sir, distinguished guests, ladies and gentlemen, this is the 16th Annual Health Research Conference that is co-hosted by the School of Medicine and Health Sciences. The conference begins today, and we shall be here for the next 2 days. So this is Thursday and tomorrow, Friday. With your permission, sir, I would like to now invite the acting provost, Reverend Justice Mutuku, to bring to us the devotional thought and the opening prayer.
Allow me, sir, to say a short prayer for opening purpose. The choir will do just a number, and then I will give us a devotion shortly, so that we do not have them to pull from the stage and come back again for the same. Father, we thank you so much for this very bright day. The sunshine is evidence and testimony. The beautiful trees and the vegetation speaks of the greatness of such a good God. We are grateful that as we think about human health, we can also think about the environment and enjoy what you have given us today. And so we hand over this program to you so that through the time of representations, we will be enriched and will be encouraged to become partakers and the good stewards of what you have entrusted into our hands. We commit this time to you now as we pray in Jesus' name. Amen. I'm told someone did a prayer this morning for the paper presentation and assured you that she was acting as John the Baptist. I hope I'll measure up then, because she said she cannot fit to my shoe, but I'm here. The assistant chaplain was there to open in the morning. My name is Reverend Justus Mutuku. I will lead us through a brief biblical reflection from the Bible, which will guide us through the discussion as we do so. John 9, 1 to 11. Let me read a story of Jesus encountering a situation where he displays what it looks like to be involved in healthcare services. John 9, 1 to 11. As he went along, he saw a man blind from birth. His disciples asked, "Rabbi, who sinned, this man or his parents, that he was born blind?" "Neither this man nor his parents sinned," said Jesus, "but this happened so that the work of God might be displayed in his life. As long as it is day, we must do the work of him who sent me. Night is coming when no one can work. While I am in the world, I am the light of the world." Having said this, he spit on the ground, made some mud with saliva, and put it on the man's eyes. "Go," he told him, "wash in the pool of Siloam." This word means sent. And so the man went and washed and came home seeing. His neighbors and those who had formerly seen him begging asked, "Isn't this the same man who used to sit and beg?" Some claimed that he was. Others said, "No, he looks like him." But he himself insisted, "I am the man." "How then were your eyes opened?" they demanded. He replied, "The man they called Jesus made some mud, put it on my eyes. He told me to go to Siloam and wash. So I went and washed, and then I could see." John 9, 1 to 11 records an account of Jesus healing a man who had been blind from birth. This event took place during the ministry, or Jesus' ministry in Jerusalem, likely shortly after the Feast of the Tabernacles, as recorded in John chapter 7, verse 1 to 8. At a time when opposition from religious leaders was intensifying. The miracle is one of the 7 major signs recorded in the Gospel of John, and each designed to reveal Jesus' identity and mission. In the Jewish understanding of the time, physical suffering or disability was often associated with the personal or ancestral sin. Therefore, the disciples asked Jesus, "Who sinned? Or was it this man or his parents that he was born blind?" Jesus challenged this common assumption by declaring that the man's condition was not the result of sin, but as an opportunity for the works of God to be displayed through him. He then employed practical means, making mud, applying it to the man's eyes, and instructing him to wash in the pool of Siloam. The result was restoration and transformation. This passage offers us 3 observations that we make that are necessary for our conversation today. First, we must learn to move beyond blame to solutions. Jesus' disciples were concerned about who sinned, but Jesus shifted the conversation from assigning fault to addressing the need. In healthcare, resilient systems are built when stakeholders focus less on blame and more on solving the challenges that hinder access, quality, and equity. Whether we are confronting disease outbreaks, workforce or shortages, health inequalities, our calling as healthcare service providers is to seek solutions that restore human dignity. The second observation is on innovation. But it says innovation is a God-given tool for healing. Jesus used the available means to bring healing, and while his power was divine, his methods reminds us that God often works through practical interventions. Today, research, technology, digital health systems, medical discoveries, and community innovations, all of them serve as instruments through which healing and well-being can be advanced. Remember Proverbs 24:3, "By wisdom a house is built, and through understanding it is established." And finally, is an element of transformation which requires collective participation. The healing involved multiple elements: Jesus, the physical resources, and the man's obedience in the ongoing in going to Siloam. Likewise, we say in the universal health coverage, this cannot be achieved by one sector alone. Governments, universities, and other healthcare providers, communities, faith-based organizations, we can name them, are involved, should be coming together to unite. As we come together today, we reflect on this as a beginning point of setting a framework on how we can be involved. And as stakeholders in healthcare, may we be inspired by Christ's example, that seeing challenges, we don't look at them just as problems, but we may see them as opportunities for innovation, for service, and the transformation of lives. In so doing, we participate in human flourishing and become partakers in what Jesus said, "I have come that they may have life and have it in full." Let us pray. And so, Father, we thank you so much that as we begin our conversations this morning and the various presentations, we have a reference point. We have a model that we can follow. Jesus himself encountered health-related challenges and displayed and demonstrated what interventions would look like. And this morning, as we hear various presenters, we pray that we will align ourselves to the vision and the model of Jesus Christ, even as we invoke your presence in this gathering, so that our time together will be fruitful, resourceful, and enabling for each one of us. We dedicate this time to you as we pray. This in Jesus' name. Amen. Welcome.
Amen. Thank you so much. Let us appreciate Provost for the word of God. And now, Professor Pamela Kimeto, the Dean, School of Medicine and Health Sciences. She will make her remarks and invite the DVC.
Kabarak University Vice-Chancellor, Professor Henry Kiplangat, President, Millersville University, Professor Daniel Wuber, Secretary, Higher Education, Dr. Carol Hunja, all the VCs and the VCs representative present here, all guests, ladies and gentlemen, good morning. Good morning. It's a beautiful day to come here today and learn from each other. And I'm going to begin by telling you a very brief story. Many years ago, a traveler was walking through a village and came upon 3 people laying stones. Curious, he asked the first person, "What are you doing?" The person replied, "I am laying stones." He asked the second person the same question, and he replied, "I am building a wall." Then he asked a third person, and the third person smiled and said, "I am building a cathedral that will serve generations to come." All 3 were doing the same work, but each saw a different purpose. Often, I think about this story when I attend gatherings like this one today. Each one of us comes here with a different role and responsibilities. Some of us are researchers, collecting data. Some are educators, shaping minds. Some are practitioners, solving problems. Others are students, preparing for the future. On the surface, it may seem as though we are doing simply the same thing, presenting papers, attending sessions, taking notes, and networking. But if we look deeper, we are doing something much greater. We are building knowledge. We are building partnerships. We are building solutions. And most importantly, we are building a future that will benefit our communities and the generations that follow us. Many of the breakthroughs that we have seen and the ones that have changed lives of many people did not begin in laboratories or in boardrooms. They began in a conversation, during a tea break, a question asked after a presentation, a challenge raised during a discussion, and a new connection between two people who had never met before. And I'm hoping that you leave here today having met a new person. And this is the reason why conferences matter. It's because they bring people with different experiences, different perspectives, and different expertise together. When these perspectives meet, innovation happens, new ideas emerge, and collaborations are born. Problems that seemed impossible begin looking solvable. And so today, as we gather here, I encourage each one of us to think beyond individual roles and institutions. Let us see ourselves as contributors to something bigger than ourselves. Let us listen with curiosity, share generously, and engage openly. By the end of this conference, the presentations may be over, and the meeting rooms are going to be empty, but the ideas generated here today may continue to inspire action long after we leave this room. And just like the third Mason said, I want us to remember that we are here today, not simply to attend a conference, but to come together so that we can build a better future. With that, I warmly welcome all of you to our conference, and I want to wish all of us a productive, inspiring, and memorable conference. Thank you. I now take this opportunity to invite our Deputy Vice-Chancellor, Academic and Research, to give his remarks.
Thank you very much, Professor Pamela Kimeto Tingei, the Dean of School of Medicine and Health Sciences. Professor Henry Kiplangat, Vice-Chancellor, Kabarak University. The First Lady of Kabarak University, Professor Gladys Kiptiony. Professor Daniel Wuba, our keynote speaker and president of Millersville University. The First Lady of Millersville University, Dr. Judith Wuba. Honorable members of the delegation from Millersville University. Honorable members of the delegation from Texas University Medical Branch. Members of the University Management Board present. Honorable guests, speakers, and panelists. The Vice-Chancellor of Laikipia University, Professor Rotich. Representatives of various Vice-Chancellors, deans of schools, directors, members of staff, students, distinguished ladies and gentlemen, good morning. We are gathered here for the International Research Conference for the School of Medicine and Health Sciences and the School of Pharmacy. The conference is taking place under the larger umbrella of Kabarak University 16th International Research Conference. As always, I take great pride in introducing our Vice-Chancellor, Professor Henry Kiplangat. I play many roles in this university, but the role that I enjoy the most is introducing the Vice-Chancellor. Professor Kiplangat has been instrumental in the leadership and development of Kabarak University since its inception in the year 2000. From that time, he has served very diligently as the University of the university, he has served very diligently as a member of the University Governing Council and the University Board of Trustees. Professor Henry Kiplangat became the Deputy Vice-Chancellor for Administration and Finance at Kabarak University in May 2015. Actually, that was like stepping down for him because he was already a member of the council and member of the Board of Trustees. But as a man of great humility, he had to step down to become also the Deputy Vice-Chancellor for Administration and Finance. And this happened in May 2015. He served in this role until December 2017, when he transitioned to his current position as the university's Vice-Chancellor, a position he continues to serve with the highest standard of professionalism, total commitment to scholarship, and unwavering integrity and service. As members of Kabarak University community, we take great pride in Professor Kiplangat's transformative and servant leadership, and underscore those two words, transformative and servant leadership. Distinguished ladies and gentlemen, as the saying goes, behind every successful man, there is a woman. At Kabarak University, we celebrate a woman who is behind the success of our Vice-Chancellor and by extension, our university. That woman is none other than Professor Gladys Jerobon Kiption, the Dean of the School of Education, Humanities, and Social Sciences. As has been our custom since yesterday and going forward, I humbly request our graceful First Lady of Kabarak University, Professor Gladys Jerobon Kiption, to walk our Vice-Chancellor to the podium. As they do so, let us give them a warm round of applause. And I humbly request them to pose for a historic photo. So cameramen, come and don't capture me in the photo.
Something else. Itaonekana kweli. Professor Daniel Wuba, President Millersville University, who is our keynote speaker. Dr. Judith Wuba, the First Lady of Millersville University. The representative, Dr. Caroline Hunja, representing Dr. Beatrice Inyangala, who is also our guest speaker. Members of the delegation from Millersville University, Dr. Oma Oluga, guest speaker, in absentia. I hope you will join us in due course. Dr. Kyoko Mwania, representing Professor Dixon Andala, CEO, National Research Fund. Professor Joseph Rotich, Vice-Chancellor, Laikipia University. Dr. Lucy Kanani, representing Professor Peter Muriongi, Vice-Chancellor, Tharaka University, which is in Tharaka Nithi County. Dr. Raphael Namwaru, representing Professor Alo Obudo, Vice-Chancellor, Masai Mara University. Professor Tenge, representing Professor Kiplangat Kotut, Vice-Chancellor, Moi University. Dr. David Kimutai Meli, representing Vice-Chancellor Professor Charles Mutai, Vice-Chancellor, Bomet University. All distinguished ladies and gentlemen, including the team from Texas University Medical Branch. Ladies and gentlemen, good morning. I would like to take this opportunity to warmly welcome you to Kabarak University and to our 16th International Research Conference for the School of Science, for the School of Medicine and Health Sciences and the School of Pharmacy. Ladies and gentlemen, our School of Medicine and Health Sciences was officially launched by His Excellency President Daniel T. Arap Moi in May 2016. Likewise, the School of Pharmacy is tracing its birth date to October 2016. Therefore, the two schools, the School of Medicine and Health Sciences and the School of Pharmacy, are clocking their 10th birthday this year. They're still young. With focused leadership, resilience, and a clear roadmap, we have made great strides in their development. The School of Medicine and Health Sciences boasts of 4 diploma programs, 6 undergraduate degree programs, and 5 master's programs. Now, the 5 master's programs are 1, Master of Medicine in Family Medicine, 2, Master of Science in Human Nutrition and Dietetics, number 3, Master of Public Health, number 4, Master of Science in Nursing, number 5, Master of Science in Clinical Medicine. In the School of Pharmacy, apart from the flagship Bachelor of Pharmacy degree program, we have 2 master's programs that are trailblazers in Kenya and the East African region. These are Master of Pharmacy in Oncology Pharmacy, which we run together, of course, with the International Cancer Institute, who are our partners, and Master of Pharmacy in Pharmaceutical Manufacturing. The ultimate goal is to set up a pharmaceutical manufacturing plant in Kabarak University. That is a dream. And those who dream and believe in their dreams know that dreams can be actualized. So we believe that in due time, Kabarak University will have that plant here. Distinguished ladies and gentlemen, the theme for this conference is building resilient health systems through innovation, equity, and multisectoral action to advance universal health coverage. And when we talk about resilient health systems, we are talking about systems that can withstand challenges and adapt to change to continue serving people when they are needed most. Over the last few years, we have witnessed the importance of resilience. The COVID-19 pandemic tested health systems across the world in ways few could have imagined. It challenged our health systems, strained resources, disrupted services, and exposed gaps that many of us did not know existed. Yet it also revealed something remarkable. It showed us the power of knowledge, innovation, collaboration, and leadership. We learned what can be achieved when institutions, governments, healthcare professionals, researchers, and communities work together toward a common goal. As universities, this experience gave us an opportunity to reflect on our role. What is our contribution beyond teaching students and awarding degrees? That's a question every university should ask itself. And the answer is, universities help shape the people, ideas, and innovations that strengthen health systems. Every doctor, nurse, pharmacist, public health specialist, nutritionist, physiotherapist, laboratory scientist, and healthcare manager begins their professional journey somewhere. More often than not, that journey starts in a university classroom, laboratory, or clinical training site. That reality places a significant responsibility on our universities. Ladies and gentlemen, first, we must also prepare professionals who can think critically, solve problems, embrace innovation, communicate effectively, and lead during times of uncertainty. Healthcare is changing rapidly. New diseases are emerging. Technology is transforming how care is delivered. Populations are growing and living longer. Expectations of healthcare systems continue to rise. As universities, we must ensure that our graduates are prepared for this changing world. Secondly, as universities, we must take our rightful place as centers of research and discovery. Many of the solutions that improve health outcomes originate from research conducted in academic institutions. Research helps us understand disease patterns, evaluate interventions, improve healthcare delivery, and develop evidence that informs policy. More importantly, universities help generate solutions that are relevant to local realities. The challenges facing our communities cannot always be solved using imported ideas. Yes, those imported ideas have a place, but we have to get solutions to our real local challenges. We need research that addresses our own context, our own populations, and our own health priorities. And this is why investment in research is not a luxury. It is indeed a necessity. Thirdly, universities have a responsibility to remain connected to the communities we serve. Those of us who listened to the public lecture yesterday, universities don't exist independent of the societies within which they are found. We should be connected to the communities we serve. Knowledge should never remain confined within lecture halls or academic journals. It must find its way into homes, clinics, schools, and communities where it can make a meaningful difference in people's lives. Through outreach programs, community-based learning, health promotion activities, and partnerships with healthcare institutions, universities become active participants in improving health outcomes. These engagements, ladies and gentlemen, not only benefit communities, but also enrich the learning experience of our students by exposing them to real-world challenges and practical solutions. Fourthly, universities have a critical role to play in leadership development. Strong health systems require strong leaders with the capacity to make informed decisions, manage resources responsibly, respond to crises effectively, and inspire confidence during difficult times. Last but not least, universities should forge partnerships. And today, Kabarak University is demonstrating that we take our partnerships so seriously. We have 2 institutions represented here from the US, and we have other institutions from our own country who are represented in this conference. No institution can build resilient health systems alone. Governments cannot do it alone as well. Hospitals cannot do it alone. Universities cannot do it alone. Regulatory bodies cannot do it alone. Success depends on partnerships. Each of us has a role to play, and each contribution matters. This conference, ladies and gentlemen, provides an important opportunity to strengthen those partnerships. It gives us a platform to share experiences, learn from one another, identify challenges, and explore practical solutions. And as we engage in the discussions ahead, I encourage us to think beyond our individual institutions and professional disciplines. We have to destroy completely this silo mentality where you want to exist alone, do things alone without involving others, and develop strong collaborative partnerships. Let us also ask ourselves how we can better prepare health professionals, strengthen research, leverage technology, influence policy, and improve healthcare delivery for the benefit of all. The future of our health systems will not be determined by the challenges we face. It will be determined by how we respond to those challenges. Universities have a unique opportunity and responsibility to be part of that response. Distinguished ladies and gentlemen, at Kabarak University, we remain committed to advancing health sciences education, supporting impactful research, fostering innovation, and building partnerships that contribute to stronger and more resilient health systems. And on that note, I am profoundly grateful to Professor Wuba and the delegation from Millersville University, and to all of you for accepting our invitation to grace the conference. I say the same of the team from Texas University Medical Branch. In the midst of your busy schedule, you are most welcome to visit our 7 schools. A tour of our university will give you a first-hand experience of our facilities, and if time cannot allow, you are welcome to visit our website, www.kabarak.ac.ke, and you will at least learn something about Kabarak University. So, distinguished conference participants, with those remarks, it is my pleasure to declare the Kabarak University 16th International Research Conference for the School of Medicine and Health Sciences and the School of Pharmacy officially opened. Ladies and gentlemen, please allow me to introduce the keynote speaker, because we are transitioning straight to the keynote speaker. Our keynote speaker today is Professor Daniel Wuba, who is the president of Millersville University, Pennsylvania, USA, a position he has held since 2018 before becoming president. Before becoming president, he served in several senior academic leadership roles in different universities, which include the University of including Washington University and Lee University, in Virginia Tech, the University of Florida, James Madison University, and Towson University. Professor Wuba is a distinguished microbiologist and higher education leader, originally from Ghana. Professor Wuba has received research support from major institutions such as the National Science Foundation and the National Institute of Health, and he is a fellow of the American Association for the Advancement of Science and the African Scientific Institute. He has advised on national science and education policy in the United States, and also serves as a traditional chief in Ghana's central region under the royal title, Nana of Fusu. Peko III. That is history in terms of to Kenyans, isn't it? That's something new to Kenyans. Let me repeat so that you can learn something. You know, learning is continuous. So his other title is Nana Ofosu Peko III. So, ladies and gentlemen, I would like you to join me in welcoming our keynote speaker to the stage, and I would like you to give him some 7 Nyayo claps. You are continuing to learn. All right, let's go. 1, 2, 3, 4, 5, 6, 7. Funga, fungua. You are wonderful learners. Thank you. Welcome, Professor.
Thank you very much. Thank you. I think I'll be okay here. Okay. I think it's okay. Thank you. Ready? Vice-Chancellor Kiplangat, First Lady Gladys Kiplangat, fellow Millersville University and UTMB colleagues, distinguished government officials, faculty, staff, health leaders, students, faith leaders, honored guests, and those joining us online. Thank you for the privilege of inviting Millersville University to Kabarak for this important conference. I come to this platform as an educator who believes that in addition to the ministries, hospitals, boardrooms, the future of health systems will be shaped in classrooms, laboratories, chapels, and communities where values are formed and leadership is tested. This year's theme calls us to build resilient health systems through innovation, equity, and multisectoral action to advance universal health coverage. This is not simply a technical agenda. It is a moral agenda because a resilient health system is one that does not fail when crises come, does not abandon rural communities because they are costly to serve, and does not separate excellence from compassion. Before discussing the broader challenges and opportunities facing health systems around the world, I would like to pause and acknowledge the remarkable institution that has brought us together today. Kabarak University occupies a unique and important place within Kenya's higher education and healthcare landscape. As a faith-based institution, it exemplifies a tradition that has long been central to healthcare delivery across Africa. A tradition rooted in service, compassion, human dignity, and commitment to improving the lives of others. Throughout our continent, faith-based institutions have often been among the first to establish schools, clinics, hospitals, and community outreach programs in underserved areas. They have not served only as providers of health care, but also as trusted partners in promoting wellness, education, and social development. Kabarak University's commitment to educating future healthcare professionals reflects this enduring mission. I would also like to recognize Kenya's leadership in health innovation. Kenya has earned international recognition as a pioneer in digital transformation, from the success of mobile technologies that have revolutionized financial inclusion to the growing adoption of digital health platforms. Kenya has demonstrated how innovation can be harnessed to improve access, efficiency, and accountability in healthcare delivery. The lessons emerging from Kenya are increasingly relevant far beyond East Africa. They illustrate that innovation is most powerful when it responds to local needs, empowers communities, and strengthens health systems rather than creating parallel structures. It is therefore especially fitting that we gather at Kabarak University to discuss how innovation, equity, and collective action can strengthen health systems and advance universal health coverage for generations to come. So, this is my argument today. It's very simple. Africa will not build resilient health systems by importing models without adaptation. We will build them by educating leaders who can connect science with service and innovation, and institutional excellence with community trusts, by treating faith-based networks as full partners in national planning, and by enabling universities to become engines of evidence, ethics, and problem-solving for the public good. In this spirit, as you've heard earlier, I invite us to see this gathering not just as a conference, but as a commissioning to educate for resilience, to lead with equity, and to build health systems worthy of the dignity of every African life. That note, let me start with the details. Universal health coverage. I need one slide at a time. There you go. Universal health coverage is one of the clearest moral promises in the global development agenda. Everyone should be able to obtain the quality health services they need without being pushed into poverty. It is not simply about having hospitals or clinics. It is about whether essential services reach people and whether the costs of care destroys household security. That is why the UN SDG target 3.8 has two sides. Indicator 3.8.1 asks whether services are actually reaching people, and indicator 3.8.2 asks whether families are protected from financial hardship. Those two questions must go together. A system that offers services to people who cannot afford it is not universal. And a system that lowers costs but does not deliver quality care is neither universal. For me, universal health coverage is both a moral commitment and an economic investment. As you heard earlier, healthy people learn, they work, they create, they worship, they lead, and they build communities. Health coverage is therefore not a social expenditure alone. It is part of the infrastructure that we have to share. As the next slide shows, Africa's UHC journey is active, diverse, and increasingly reform-oriented. The 2025 Journal of Global Health Review of Health Financing Reforms in the World, what we call the World Health Organization African region, found widespread efforts to reform revenue raising, pooling, purchasing, and public financial management. The map on this slide is important because it demonstrates movement from aspiration towards policy architecture. Countries are refining insurance schemes, enacting health insurance legislation, or placing reforms on the policy agenda. But the map also signals variation. Some countries are advanced in legislation but face implementation challenges. Others have political commitment but weaker institutional capacity. Financing reform is essential, but it must be accompanied by service readiness, workforce availability, reliable data, accountable governance, and trusts. The African UHC, as you see here, should not be told as a deficiency. It is a story of experimentation, commitment, and leadership under constraint. The opportunity is to convert reform energy into measurable gains in access, quality, and financial protection. And overall, the world has made real progress towards this promise of UHC for everyone, and we should acknowledge the promise before confronting the gaps. Next slide. Current data, as shown on this slide, is encouraging. Since 2000, the global UHC service coverage index has improved substantially, rising from 54 to 71. Coverage improved in 97% of countries, and the number of countries with low coverage fell. That is not trivial. It represents expanded immunization, improved infectious disease control, more access to essential services, and decades of public investments. Kenya's line is also important, as you can see on the slide. The country moved from a very low service coverage index in 2000 to a much stronger position by the early 2020s. This means that progress is possible, and it means that policy choices can matter. But the chart also shows a second truth. The African region remains well below the global line Improvement has occurred, but the distance from the global average remains substantial, as you can see here. So this is not a story of failure. It is a story of unfinished progress. And unfinished progress is exactly where leadership matters most. The challenge is that progress is no longer moving fast enough. Next slide. This slide is the inflection point. Before 2015, the UHC service coverage index improved at roughly 1.5% per year. Since then, progress has slowed down to about 0.5% per year. In other words, we are now moving at roughly 1/3 the previous speed. That slowdown matters because UHC is not achieved through declarations. It is achieved through sustained movement in service access and financial protection. If you look at current trends, the world is projected to reach a global service coverage index of only 74 by 2030, which is going to be short of the goal of 80. And the composition of progress also matters. Much of the earlier gain came from infectious disease control. That's important, but it does not complete the UHC agenda. Maternal health, child health, non-communicable diseases, mental health, and primary care require continuing investment. If we celebrate, and that's the aggregate progress, without examining where progress is stalling, we risk designing systems that look strong on paper, but fail people at the point of need. And when systems fail at the point of need, families often pay the price. So let's look at the next slide. The most painful measure of an incomplete health system is not only whether people get sick, it is whether getting care makes them poorer. In 2022, 2.1 billion people faced financial hardships from health costs, and 1.6 billion of them were pushed into or deeper poverty. That means illness becomes not only a health event, but an economic shock. The out-of-pocket spending comparison helps us to see the financial challenges that they cause. Now let's take a look at Kenya. In Kenya, the out-of-pocket spending is lower than other sub-Saharan African countries, but it remains significant. Any out-of-pocket burden at that scale forces families to make impossible choices. Do they pay for care or pay for school fees? Do they seek treatment or protect household savings? Do they buy medicine or do they buy food? We should be precise here. Out-of-pocket spending is, as a share of the current health expenditure, is not exactly the same as the SDG catastrophic spending indicator. But both point toward the same policy lesson, which is financial protection must be designed intentionally. It cannot be an afterthought. These financial and service gaps are especially urgent on the African continent. Next slide. The WHO African region sits about 20 points, as you can see, below the global coverage index. That gap is more than the statistical difference. It represents mothers who travel too far for delivery care, children who miss vaccines, patients who cannot obtain treatment for chronic diseases, and communities that remain too distant for dependable services. It is also important to frame this gap with fairness and context. Africa is not defined by deficit. Africa has innovation, talent, young populations, universities, faith institutions, entrepreneurs, and communities with deep social capital. But the continent also carries a heavy burden of disease and an immense workforce challenge, while operating in a global health economy that has often left African systems dependent on external supply chains and donor priorities. That is why resilience by design is so important. The goal is not simply to catch up to the global average. The goal is to build systems that are locally governed, equitably financed, trusted by the communities they serve, and prepared for these economic shocks. And one of the most binding constraints in that system is the healthcare workforce. Next slide. Health systems are built by people. Technology matters, that's true. Financing matters, it's also true. And buildings are important. But no system delivers care without trained, supported, trusted, and retained healthcare workers. The workforce gap is stark. The widely cited WHO-UHC threshold is 4.45 physicians, nurses, and midwives per 1,000 people. The WHO Africa region is far below that threshold, and the projected global shortage of health workers by 2030 is expected to fall disproportionately on Africa. More universities, such as Kabarak, are ready to help. This is where the mission becomes very concrete. Workforce development is not a side contribution to health system resilience. It is central. Every doctor, nurse, midwife, community health worker, pharmacist, data scientist, and healthcare administrator is part of the architecture of resilience. So when we talk about universal health coverage, we are also talking about the educational policy, training capacity, research, retention, and professional dignity. This brings us to the central thesis of this address. Resilience that doesn't occur by accident or by luck. Resilience is sometimes, next slide please, used as if it means endurance alone. But in health systems, resilience is more than surviving a shock. A resilient health system prepares for shocks, absorbs them, adapts during them, transforms them whenever necessary, and learns afterward. And most importantly, it continues delivering essential care while the shock is happening. You heard about the COVID. That is why resilience must be designed. It depends on governance that can coordinate across levels, and it also depends on financing that can protect the poor. It depends on the workforce that is trained and supported, and also on medical products and supply chains. COVID-19 revealed this truth globally. Systems that had community trust, primary health care, surveillance, supply chain flexibility, and adaptive leadership were better positioned to respond. Systems without those services paid a higher price. But no single institution can design or deliver the resilience alone. So next slide. Let's look at the various groups that have to work together. UHC coverage cannot be delivered by the government alone, as you heard earlier. Even though government has the central stewardship role, it cannot be delivered by hospitals alone. And also, it cannot be delivered by faith institutions alone. It requires collective stewardship. It's as simple as that. Government sets policies, financing, regulation, and accountability. Universities develop the workforce, generate the evidence and ideas, and also test innovations. Faith-based institutions often extend trust and care to places where formal systems struggle to reach. The private sector contributes supply, technology, and investments, and communities provide legitimacy, feedback, participation, and trust. At the bottom of this slide, the phrase says a lot. Equity must be designed into governance, not added later. If equity is treated as a late-stage adjustment, the system will reproduce the inequalities that it inherited. So it should be in it up front. If equity is built in this governance from the beginning, then every policy question becomes sharper. Who is reached? Who is left out? Who pays? Who decides? And who is accountable? Kenya offers a powerful living case for these questions because of its devolved health system. Next slide. Kenya's devolved system is a compelling case for resilience by design. Under the 2010 Constitution, health service delivery moved to the 47 county governments. This brought decision-making closer to communities, which is a major opportunity for equity and responsiveness. But proximity alone does not guarantee performance. Devolution also creates coordination challenges. Counties differ in their fiscal capacities, infrastructure, workforce availability, disease burden, and management strength. And a devolved system therefore requires strong national standards, fair financing, county capacity, and mechanisms for learning across jurisdictions. The numbers on this slide point to the scale of the challenge. 47 counties now manage health delivery. Kenya spends about 4.3% of its GDP on health, and about 24% of health spending remains out of pocket. That combination tells us that governance and financing must be designed together. And Kenya is not simply a case study. It is a living laboratory for how African systems can move from UHC aspiration to operational architecture. We can see that architecture emerging in recent Kenya reforms. Next slide. Kenya has taken important steps towards building the machinery of the UHC. The deployment of 100,000 community health promoters across all 47 counties represents a serious effort to strengthen the front line. Community health workers are often that bridge between households and the formal system. The Social Health Authority, launched in October 2024 to replace the NHIF, represents another major reform in Kenya. Financing architecture matters because UHC cannot depend mainly on what a family can pay at the point of care. But honestly, reform is not the same as completion. The NHIF to SHA transition has had documented rollout difficulties. That does not mean the reform is unimportant. It means implementation is the real test. The question is not whether a policy is announced. The question is whether it reaches the patient, protects the poor, supports providers, and produces measurable improvements. And that test becomes clearest when we look at the equity frontier, maternal, and last mile care. So let's take a look at what we have here. This slide shows why averages can be misleading. Kenya's DTP3 immunization coverage is strong compared to the global and regional figures. That is real progress and should be acknowledged. Yet at the same time, maternal mortality remains a profound challenge. The slide shows the WHO and Kenya Health Information System figure of 355 maternal deaths per 100,000 live births, with the reminder that a World Bank modeled estimate is lower because it uses a different method. We should not blend those figures. We should use the figure we cite and be transparent about the caveat. The broader point that I want to make is this. High coverage in one service area does not mean equity across the whole system. Resilience is tested where the system is weakest. It is tested in rural counties, among poor households, among women seeking emergency obstetric care, among people with chronic diseases, and among communities far from well-resourced facilities. This is where faith-based providers become especially important. Next slide. Faith-based providers occupy this distinctive place in African health systems. Their importance is not only the number of facilities they operate, it is also the trust they carry, the communities they reach, and the moral language of service that often guides their work. In Kenya, CHAK and the Kenya Conference of Catholic Bishops are estimated to account for about 40% of the country's health facilities or beds. Those numbers show a network that is not peripheral. It is part of the health system fabric. But we must frame this responsibly. The 40% estimate is a facility or bed estimate, not a claim that 40% of all care received by households come through faith-based providers. The point is that faith-based providers are essential last-minute partners and should be integrated into the strategy, financing, data systems, and emergency preparedness. And this same logic applies to universities, especially, such as one where we are now, Kabarak University. Next slide. Universities are sometimes described as ivory towers. In health system resilience, they should be understood as engines. They train the workforce, they generate local evidence, they validate new tools, and they prepare leaders who can operate across sectors. For a university like Kabarak, this role is especially powerful because faith-based higher education can combine technical excellence with moral purpose. Workforce development is one pathway, but applied research is another way that universities contribute. And policy-aligned innovation is a third. Together, they allow universities to convert aspiration into trained people, data, and working solutions. My own work as a scientist and educator has shown me that African capacity is built through long-term investment in its people. Laboratories matter, mentorship matters, and institutional partnerships also matter. But when universities align their mission with national health priorities, they become anchors of resilience, not observers from the sidelines. And the role of universities becomes even more important as new technologies enter the health system. Next slide. Innovation is essential, but innovation is not automatically equitable. A digital tool can extend care to the last mile, or it may widen the gap between people who are connected and people who are not. Artificial intelligence can help clinicians and community health workers, or it can reproduce bias if it is built on data that do not represent African populations. I think yesterday I mentioned that information. Given that AI basically depends on large language modules, if we don't put the right information into these LLMs, the data or that's the predictions or results that it will give us are most likely going to be faulty. But Kenya has a few promising examples. The AI-enabled chest X-ray tools for tuberculosis, digital support for community health workers through the CHIS program, and telemedicine expansion during COVID. All of these point to the possibility of extending reach. But we should avoid the hype of using technology. The evidence-based for many African AI health tools is still very thin, and validation studies remain limited. So the right call is not to reject innovation, but do it in context. Resilience also requires innovation in what Africa produces itself. I think I mentioned this yesterday, that for Africa to succeed, to be able to address its own challenges, we shouldn't wait to import what someone has done and try to use it without adapting it to our system. The right call is to govern our own approaches to handling this resilience. Next slide. The COVID-19 pandemic exposed a hard truth. A health system is not fully resilient if it cannot obtain essential products when the world is under stress. If vaccines, diagnostics, medicines, and protective equipment must come almost entirely from outside the continent, then African systems will remain vulnerable to global supply disruptions and geopolitical bargaining. Let's just cast our mind back to what happened in the Strait of Hormuz. And imagine if you have to wait to get your medication and it's not coming. So it is time for us to start developing our own medication on this continent. And it's not as if we don't have it. We have people with expertise. We have grandparents, aunts, uncles, who know the various herbs that can be used to treat particular diseases. How are we using that knowledge? Today, Africa imports nearly all of its vaccines. And the AU and African CDC target of producing 60% of Africans' vaccines on the continent by 2040 is therefore more than industrial target. It should be a resilience target. If by 2040 we are not producing 60% of our vaccines on this continent, we will be falling back. Manufacturing sovereignty requires regulatory capacity, financing, procurement commitments, quality systems, technology transfer, research partnerships, and regional coordination. And as you just heard this morning, Kabarak University is in the process of having a manufacturing plant on its campus. That is a model. If every university thinks about how can we contribute towards producing medicines for our people, that will make a big difference. But is that what Kabarak is doing? Should be a model for others to follow. How many people are doing so? So it goes back to then the importance of this conference. We are talking about things that should be shared with others. Again, resilience is designed. It is not by accident. It is built through institutions that can sustain capability before the next shock arrives. And the same design principle applies to money or the financing. If we design the money, we design the equity well. Next slide. Health financing is not merely an accounting problem. It is an equity design problem. Who pays? When do they pay? How risky is it for them to pay? And who receives protection? These are all questions we should be asking as we make our moral and policy choices. The evidence suggests that recent reductions in health-related financial hardship have been driven largely by poverty reduction rather than by stronger financial protection within the healthcare system. That means countries cannot assume economic growth alone will solve the health financing problem. UHCs require deliberate policies. Let me share these three with you. These three design principles can help improve what countries do. First, they should consider pooling funds so that households are not paying mainly at the moment of illness. Second, they should protect the poorest through subsidies, exemptions, and targeted support. And thirdly, we should spend efficiently by investing in primary care, prevention, and services that can produce the greatest health benefit. We shouldn't go to the hospital only when we are sick. That is often the case in Africa. If we don't go to the hospital for preventative measures, it actually increases the costs when we are sick. And that's part of the culture that we need to change. In my own family, back in Ghana, there are people, actually, I was talking to my uncle last week. I said, when did you have your recent annual checkup? He said, I'm not sick. Why should I go for a checkup? And that is it. But that is how the system is currently designed. Each time you go to the hospital, you're going to pay a lot. So you don't feel like being proactive. But that is what we need to do to help us to be able to keep the costs down and be more resilient. Kenya's 24% out-of-pocket share is therefore not only a statistic, it is a policy target. And reducing that burden is part of making UHC real in Kenya. COVID showed why these design choices must be made before the shock occurs. Next slide. It was a global stress test. It revealed the strengths and weaknesses of health systems in every region of the world. One of its clearest lessons is that resilience cannot be improvised in the middle of the crisis. Primary health care keeps essential services running when hospitals are under strain. Public health and surveillance detect threats very early. The lesson is not simply to prepare for the next pandemic, but rather to build systems that are strong every day, because this strength is what becomes necessary during emergency situations. A system that cannot deliver routine maternal care, immunization, chronic disease management, and trusted community services in normal times will most likely struggle during a crisis. So, getting to the end of this presentation, we have to think about a call to action. This is very straightforward. We have to move from commitments to measurable outcomes. Next slide. I want to close this presentation with 4 moves that can turn the aspiration of UHC into measurable progress on this continent. First, we need to consider integrating faith-based institutions into national health strategies. They should not be treated as add-ons or emergency substitutes. They should be included in the planning, financing, data systems, referral networks, workforce development, and emergency preparedness. And I'm glad to say that Millersville has a strong program in emergency preparedness. So we'll be glad working with Kabarak to make this available. Second, they should align innovation with equity. New tools should be validated in African settings, governed with care, and designed for the last mile. If technology reaches only those who are closest to it, it has failed the equity test. Third, we should embrace collective stewardship. As I said earlier, one unit cannot provide this resilience. Government, universities, faith institutions, the private sector, and communities must operate as one system with shared accountability. And finally, we should track measurable outcomes. Aspirations matter, but outcomes will change lives. We should set targets, we should report our progress, and learn from gaps and adjust as we go along. These are my suggestions from what I read. So the question is, why do we need to do this now? If you look at the current trends, the world will miss the UHC by 2030. The goal was to get, 74 out of 80, I don't think we're going to make it. But agencies should not produce despair. It should produce disciplined hope. That brings us back to the central choice we have before us. As I mentioned at the beginning, this is a commissioning. It's not a content delivery. What I'm proposing here is that resilience is a choice. It is a choice made in budgets, in curricula, in health financing systems, in county plans, in research partnerships, and in how we listen to communities. The message I hope we carry from this conversation is simple. Universal health coverage will not be achieved by aspiration alone. It will be achieved when leaders design systems that are equitable before crisis, trusted before crisis, financed before crisis, staffed before crisis, and we are able to learn when these crises occur. Kabarak University and similar institutions have a vital role to play. Kenya can lead. African universities can lead. Faith-based providers can lead. And government can lead as well as communities. But we must all lead together, not as individual systems. Let us move from vision to viability, from commitments to outcomes, and from resilience as a slogan to resilience by design. And to share just a quick personal story, this is one that talks about this resilience. My wife and I lost our parents under circumstances that we believe if they got the right health care, we are people of faith, it was their time to go, but what they went through before they passed was one that we believe could have been better handled. And so in Ghana, for those of us in diaspora, when you come in and you basically make those points out, you tell people about it, they will often say, yeah, you live abroad, you have everything, how dare you come tell us what we should do? So they often look at us as people who are complaining. Okay? And so the issue was, I was talking to one of my family elders, and what he said was, look, if you find this as a problem, then fix it. I'm not a physician. My wife is not a physician. So what we did was we put our heads together, and we had some family members who are physicians, including our own daughter, and we opened a new clinic in Ghana with 18 beds. And the story that I'm going to share, the most important thing about this story is 2 weeks ago, we were at that hospital. We had spent most of the day there. We were about to leave. Just when we were about to leave the compound, we heard this, there was a motorcycle, flashing its lights, and behind it was a taxi. We knew there was a crisis. And they were yelling as they entered our hospital. We were about to sit in our vehicles to leave. What happened was that this gentleman was 45 years old. He had just had a stroke, has diabetes, he has hypertension, and there was no way this person was going to really be taken to a hospital that can save him within 30 miles. Our hospital was 15 minutes away. So they brought him there. According to the physician in our emergency room who took care of him, if they had waited another 15 minutes, the patient would have died. It comes, to all of us to find ways to solve this problem. He was stabilized. He stayed in the hospital for 3 days, and then we sent him to a major hospital for other, care. All that I'm saying is the challenge we face is one that we either have to take action and stop complaining about it, and find ways to build resilience into the healthcare system in Africa. Thank you very much for listening to my thoughts, and I welcome any questions. Thank you.
Another warm round of applause for our keynote speaker. Thank you very much, Professor Wuba, for that very powerful keynote speech. To make sure that you remember the Kabarak University claps, let's give him 5 Nyayo claps. 1, 2, 3, 4, 5. Funga, fungua. Funga means close. Fungua means open. So at this point, we would like to invite the next speaker, Dr. Carol Hunja, the Secretary for Higher Education in the Ministry of Education. Representing the guest speaker, Dr. Beatrice Muganda Inyagala, the Principal Secretary, State Department for Higher Education and Research. So please help me welcome Dr. Carol Hunja. Let's give her 3 powerful Nyayo claps. 1, 2, 3, funga, fungua. Welcome.
Vice-Chancellor, Kabarak University, Professor Henry Kiplangat, and in keeping with the culture, First Lady, Gladys Kiplangat, President of Millersville University, Professor Daniel Wuba, and the First Lady, members of the Millersville University delegation. I met them on Tuesday in the State Department. Karibuni sana. Other Vice-Chancellors present, distinguished scholars, researchers, students, ladies and gentlemen, good morning. Before I read the remarks of the Principal Secretary, I would like to start by sending her warm regards to you. She would have truly loved to be here, and even Professor, the VC, told me she was coming, but then something else came up, and so she asked me to come and be with you. She offers her deepest apology for not being able to join you, and she also offers a deep, warm regards to you all, and wishes you a great stay here at Kabarak University. Allow me also to recognize a few people. Firstly, I want to recognize my long-term friend, who happens to be the dean of this school, Professor Pamela Kimeto. We schooled, you know, in Kenya, currently we need to keep proving our academic credentials. Otherwise, you can be told that you are a fake academician because you offered a fake certificate. So nowadays, we prove by the people we schooled with. Makes it easier. So I'm truly honored to be hosted here for the first time by Professor. She was telling me a very funny story. Please allow me to give it to you. He tells me that we walked into an English class and we wrote an essay, the first essay we ever wrote, and then I used the phrase "in the nick of time." And then she wondered, who uses such a phrase? Which high school did I go to? I've never heard of such a phrase, and I cannot imagine, because we've not seen each other for more than 20 years, not that even. And she remembers that. It's very interesting. So wonderful memories from people we schooled with. I'd also like to recognize DVC, like Laikipia, Professor Kanjogu. I saw you somewhere. Yes, good friend. For a long time, I saw someone else that I know. Professor Tenge. Professor Tenge, he was mentioned to have come to represent Moi University. He's the principal, College of Health Sciences at Moi University. And everybody else who knows me, thank you very much. Hello, everyone. I'd also like to indicate that this is my first time at Kabarak University. Truly honored to be here during the conference. And when President of Millersville gave that powerful speech, we really need to think very seriously as universities on the role we can play to ensure that we have a resilient health system. We cannot afford to continuously be in the periphery and continuously complain and say how shu, she, that's what we call it, how it is not working. We cannot afford to do that. We need to be part of the solution. And there are so many ways in which we can develop such solutions. One of them is demonstrated here through the very strong partnerships that we have with the international community. I had a great interaction with Millersville University, and they have amazing programs. Any university that is represented here, kindly, this is a great opportunity to interact with Millersville University, to interact with Texas as well, and make sure that you develop great relationships here. They have an ambitious plan to establish a consortium of Kenyan universities, and even regional universities, I'm sure, where they deal with various aspects, nursing, social sciences, medicine, etc. They also are looking to develop global graduates. They have an amazing program where they want to develop graduates that can work anywhere in this world because they possess a certificate, say in Kenya, and another certificate from Millersville, dual certificates. And this is where we're heading as a country, and you know, in terms of ensuring that our graduates remain relevant and are able to work anywhere in the world. And so please let us use this opportunity to develop partnerships as has been already exemplified by Kabarak University. Let us also join them and see how, with our many brains, we can come up with great solutions for this country. With those few remarks, allow me to now read the keynote speech from my boss, Dr. Beatrice Inyangala, Principal Secretary, State Department for Higher Education. It gives me great pleasure to join you today at this important international conference, whose theme is Reimagining University Education for an AI-driven, competency-based future. It's quite timely and relevant as we navigate the rapidly changing landscape of higher education. Allow me from the outset to congratulate Kabarak University for organizing this conference and creating a platform that brings together leaders in academia, in research, in innovation, industry, and policy. These engagements are indeed very critical in shaping the future of our universities and ensuring that our institutions remain responsive to the evolving needs of our society. I wish to extend a very warm welcome to Professor Daniel Wuba and the entire Millersville University delegation to Kenya. Your presence here, and of course to Texas University as well, presence here demonstrates a strong commitment to international cooperation, academic excellence, and global citizenship. We are indeed honored to have you as our partners and our guests in this country. Ladies and gentlemen, the future of higher education will increasingly depend on partnerships. No university, regardless of its size, resources, or reputation, can successfully address the complex challenges of the 21st century in isolation. Collaboration is no longer optional. It is a strategic necessity. In the State Department for Higher Education, I happen to be the person who's in charge of partnerships and collaborations, and I think Millersville will confirm that we are always welcome. You're always welcome. We welcome our partners, and we take our relationships very seriously, because it is through these collaborations that we are able to build an amazing, though it's a cliche that is used, global village, because nowadays we are constantly traversing different parts of the globe, and so no problem is isolated per country nowadays. We all seem to face the same collective problems because we are not islands. We constantly move around. And so partnerships remain really, really important through these engagements. Today, I wish to particularly applaud the partnership that has been forged between Kabarak University and Millersville University. I'm also aware of the other collaborations that Millersville has established with the University of Nairobi, Moi University, the Raka University, and Masai Mara University. I reiterate, if your university has not been mentioned among this, kindly do not leave this place without an MOU with Millersville or Texas. These collaborations demonstrate the immense value of international academic engagement in advancing research, innovation, faculty development, student mobility, and institutional growth. I wish to specifically recognize and commend President Daniel Wuba for his visionary leadership and personal commitment to strengthening the academic cooperation between the United States and Africa. Professor Wuba, your decision to visit Kenya and engage directly with our institutions reflects exceptional leadership and a genuine belief in the transformative power of higher education partnerships. I was quite intrigued to learn that Millersville has actually been operating in Kenya for quite some time and in other parts of Africa. And they have various activities that have been ongoing. And I was quite impressed because most of the time collaborations usually start from zero. But this is a collaboration, and Millersville has been working already. It's already working in our institutions, and that's really, really impressive. Indeed, Millersville University has set a commendable example for other institutions within the Penn State system of higher education. Millersville University is one of the 13 universities that make up Penn State system of higher education, and this commitment, but I think you mentioned there are now 10? 10, yeah. So the commitment demonstrated by Millersville, they ended up being 10 because some of them merged, right? I remember that in our discussion. Should inspire broader engagement across the entire system. Through you, President Tuba, I wish to extend a special invitation to the other sister universities within the Pennsylvania state system of higher education to continue and to also embrace Kenya as a strategic partner in higher education. We know you'll facilitate that. We welcome collaborations in research, innovation, student and faculty exchanges, joint degree programs, entrepreneurship, digital transformation, healthcare, education, and community engagement. By the way, they have a nursing program. Remind me the name? Nursing practitioner. Nursing practitioner. They have a nursing practitioners program that they want to establish in Kenya. Professor Kimeto, yes, do that. You set the space, it will now be embraced in Kenya, indeed. I would like, Kenyan universities have talented faculty, ambitious students, vibrant research ecosystems, and growing innovation capacities. These are immense opportunities for mutually beneficial partnerships that can advance knowledge, strengthen institutions, and contribute to global development. I would also like to challenge our Vice-Chancellors present here today. As leaders of our universities, we must continuously seek opportunities for strategic partnerships, both locally and internationally. They should not, these partnerships, be viewed merely as ceremonial arrangements documented through memoranda of understanding. By the way, I used to be a director of linkages and partnerships in a university, and I know what happens. I have done it. We sign an MOU. How many targets? We have a target of 10 MOUs per academic year. Know what I used to do? Be honest to God. I stand in front of you very ashamed to tell you this story. I used to go and collect 10 MOUs very quickly within the first and second quarter of the financial year. Anybody else who comes in the third and fourth quarter, I delay for the next financial year because I need to fulfill my targets. I am ashamed to say this story in front of you, but that's what we do. PS, now I'm a PS, I say, they should not merely be ceremonial arrangements, documented and filed. We should consistently ensure that we implement those partnerships. Having told you such an shameful story, I would also like to indicate that I was a director of research, innovation, and commercialization, and so I still managed, through some of those partnerships, to implement and develop amazing things with them. So, as much as I'm ashamed for the things I used to do, I still ensured that research, innovation, and commercialization was greatly greatly thrived in my institution. So let us ensure that our MOUs translate into tangible outcomes that benefit students, faculty, researchers, and society. Kenya is currently really privileged because we have an environment that continues to grow and thrive and grow our universities. When I became a director of research, before I joined the State Department for Higher Education in my previous university, that was about 5 years ago. We did not have a lot of instruments in place. But today, we even have a State Department for Research. And that shows you the level of commitment that the government has. And it has identified that in Kenya, we have a lot of potential, but we can only grow by driving our manufacturing, our digital world and technologies, and our industries. Then we can produce for our own consumption and reduce the number of imports that we bring into the country and enhance the exports out of the country. I challenged Millersville University to start bringing students to Kabarak University from the US. We cannot continue boasting, I studied in the UK, I studied in the US. How many of them come and boast and say, I studied for a quarter or a year in Kenya? How many? We boast very proudly. I want to start hearing students, graduates from Millersville, coming to Kenya and boasting to us and telling us, you know, I did part of my studies in Kabarak University. What an amazing achievement that would be. This is the direction we're moving in. Internationalization of our academic degree programs. Let us actively pursue collaborations that result in joint research projects, faculty exchanges, shared labs, co-supervision of postgraduate students, innovation ecosystems, commercialization of research outputs. to ensure that these partnerships are meaningful and ensure that we are transformative and students succeed in all that they do. Government of Kenya remains committed to strengthening the quality, relevance, and competitiveness of our university education. Quality, so that even students from our global neighbors will be interested to come here and study in our universities, because we have very unique issues that govern our culture, our existence. And so we have highly attractive. Let us continue bringing and ensuring that we have attractive environments where other people can thrive and gain from us. Kenyan universities are quite committed with key priorities in embracing technology as an enabler of teaching, learning, research, and administration. Our universities are increasingly integrating digital technologies, artificial intelligence, data analytics, virtual learning platforms, and emerging technologies in education into their operations. We recognize that the future workforce will require new competencies, hence our education system, competency-based education. In the universities, we have competency-based education and training, because in the universities, that's where we're incubating this workforce that requires very necessary competencies to thrive in our shifting, ever-dynamic, technology-driven world. Equally important, very important, vice-chancellors in here, lecturers in here, other academic staff, please listen to this. We need to constantly go for continuous development. You cannot remain negative as far as AI is concerned. We cannot afford to say that students who use AI only plagiarize. Every time I stand in front of a team, of a group like this, I tell them, you know what, tough on you. When we were doing our PhDs, we had to go to libraries to look for books. We had to look for publications. I was telling people how I would write to my friends in other countries where they have database access for this publication, so they can send the publication to me, so I can be able to access it. Tough on you. Now we have AI. All the publications that are relevant in this world have already been uploaded in AI. Tough on you. What would take you 1 year to write a single paragraph is taking these young people 2 seconds. Well-written material. Start the wacheni wivu. What I'm saying is, let these older people stop being jealous of the young people. This is where we are. Let us stop being jealous of these young people that they have technologies that are enabling them to complete their PhDs faster than we did. I'm sorry. I'm very sorry. By the way, even I and Professor Kimeto, we completed our PhDs much faster than our predecessors. Tough on you. We need to start thinking of how we can embrace AI, because it is here to stay. Let us, as universities, be at the forefront in embracing these technologies. Professional development, please look for ways in which you can develop yourselves to ensure that when we educate our students, they don't look at us bored, because we are teaching them age-old notes. They are already way ahead of us. The success of our students is the true measure of the success of our institutions. Allow me once again to thank Kabarak University for hosting this conference and for facilitating this important engagement with Millersville University and Texas University, I thank President Uba and his delegation for choosing Kenya as a partner and for sharing their experiences and expertise with us. As you engage with our universities and institutions over the coming days, please do find some time to experience Kenya. On your way here, pass by Lake Naivasha, Lake Elementaita. Nakuru National Park is located here. To me, I think it's one of the best national parks in the country, other than, of course, Masai Mara. Please take your time to go out and engage and enjoy the beauty that is Kenya. Kenya is a country blessed with extraordinary beauty, rich cultural heritage, world-renowned wildlife, and warm hospitality. Whether it is our magnificent national parks, the Great Rift Valley, where we are, our coastal attractions, or our vibrant cities, we hope that you will leave this country with lasting memories and become ambassadors of Kenya wherever you go. May this conference deepen existing collaborations, inspire new partnerships, and contribute to a stronger and more globally connected higher education sector. I wish you fruitful deliberations and a successful conference. Thank you, everyone, and God bless you all.
Good. Remember where you are. 3, near your claps. 1, 2, 3. Funga, fungua. Thank you very much, Dr. Carol Hunja, for representing the Principal Secretary for the State Department for Higher Education. When I meet her, I will give her a positive report that you did not let her down. So thank you very much for that speech. Please allow me to make you happy when it comes to memorandum of understanding signed by universities. You shared your experience. As you go back, I want to tell you there is hope. And that hope has been demonstrated by Kabarak University. We sign MOUs, not just for ticking a box, but we sign MOUs which we operationalize. That is Kabarak University for you. Today we have Millersville University, the president is here. We have worked with them. This is not the first time, but several times. Texas University medical branch, we have also worked together with them. And I just want to give you another example, which is not in medical field. Kabarak University and University of Venda in South Africa have established the African Musicology Institute, the first one in the continent, and we have signed an articulation agreement which indicates how we implement the process. 2 of our students are in University of Venda as we speak. So take that message to the Principal Secretary and tell them universities in Kenya, exemplified by Kabarak University, are doing the right thing. Secondly, on artificial intelligence, you talked about it. I would like to humbly report to you that Kabarak University is one of the few universities in this country with an artificial intelligence policy, which has guidelines on how to implement it within their institution. We are not running away from it. And so you can set institutions to come and benchmark with us. We even have a master's degree program in artificial intelligence, so we are doing well. I think those are the ones I just wanted to mention to you. If there's anything else, I will come back and remind you. Yes. All right. Now we have another guest who is going to make a presentation online. Dr. Ouma Oluga, the Principal Secretary, State Department for Medical Services. And I would like to take this opportunity to welcome him to make his presentation. We can also welcome him by giving him 3 Nyayo claps. 1, 2, 3. Fungua. Thank you very much.
Thank you so much, Professor, and thank you also to everyone who is joining us for this conference. Those of us that are visiting from elsewhere, we welcome you to Kenya, and we want to assure you of enjoying very good weather, and also please take time to see more of our country. So, Professor and all the distinguished delegates, President of Millsville University, the distinguished colleagues, researchers, the partners in the room, and also those that are following online, good afternoon. I'm very pleased to be part of this conference. I would have loved to join you, and I'm very pleased to have the opportunity to address you virtually on this serious topic of building resilient healthcare systems. Every nation eventually has to answer only one question very honestly. When one of the citizens is sick, frightened, and has nowhere else to turn, does the system built in that citizen's name actually hold? Kenya is now 18 months into answering that question at a scale that few nations have come to learn from. We have hosted delegations from Ghana, from Zimbabwe. We've hosted delegations from Egypt, and even delegations from the UK to look at what Kenya is building. As of this month, 31.39 million Kenyans, and that is close to 66% of the population, that is 2 in every 3 citizens, have registered under the Social Health Authority. 9 million have already drawn services under the Primary Healthcare Fund. 4.4 million have accessed specialized care through the Social Health Insurance Fund. And this is what we call Taifa Care. Taifa meaning nation, for those of you that are not Kenyans or that are not conversant with the Swahili language. It's the largest health financing mechanism and also the largest health financing transition that this country has ever undertaken, and one of the largest underway anywhere in the African continent today. But I'm not here to recite those numbers or even that achievement, because numbers of that size are very easy to talk about. What I'm here to talk about is our participation as researchers, our participation as universities, so that we find opportunity to make it more useful, to make it more valuable for the Kenyan citizen and for anyone in the world that is looking for solutions of how to build resilient healthcare systems. Indeed, we all exist only for one purpose, whether you are government, whether you are a researcher, whether you are in a university, that we provide value, that we solve the problems that bedevil the world. And so I'm here to explain the architecture that has to exist underneath those numbers. And I am also here to say very candidly how this architecture was built, and also to invite you to research into it, perhaps to use it in your models so that we improve it, so that we can make it work. Kenya's legal foundation for this transition is already complete. And this started by enactment of 4 pieces of legislation. One, the Social Health Insurance Act, which was done in 2023, the Primary Healthcare Act, again done in 2023, the Digital Health Act, again done in 2023, and what we call the Facility Improvement Financing Act. These 4 acts replaced 4 decades of a fragmented insurance model with a single architecture. And these were very important because Article 43 of our Constitution of Kenya made health as a right in 2010. The Supreme Court of Kenya would later make a ruling that these rights that were in the Constitution should be realized progressively. 10 years after Kenya implemented that Constitution in March of 2013, the country had to move forward and to begin a journey of realizing the constitutional right to health. And therefore, these statutes did not just come because they were the administration's aspirations or an act of cleverness. They came because they were a fundamental right, a contract with the Kenyan people that required every citizen to have a system that can respond to that one question honestly. Do they get the healthcare services that they seek when they are in need? This required that the financing is restructured. It also required that there is visibility through data so that policies and resources are deployed within a pipeline that can be traced, within a pipeline that can be accounted for, but more importantly, within a pipeline that delivers the dignity with which health must be upheld. Kenya is building this architecture in an environment of significant disruption. Number one is that the global health financing landscape has changed. Just in 2025, we had stop work orders from the United States government. These are huge traditional bilateral partners. We had deprioritization of health from the Foreign Common Development Organization, or the UK government, if you were to call it as so. We have also had a lot of downscaling of financing from Global Fund. We've had notices for the wind down of serious development assistance from Danida and many other resource flows, including philanthropic foundations that have been moving more and more away from health for the last 2 decades. This means that every country must answer only one question. Can your healthcare financing mechanism enable you to stand on your own? And so the development of this health financing mechanism through the Social Health Insurance Act that birthed the Social Health Authority was urgent, as it was also necessary, because in an environment of shifting global health financing, it is important that resilience, which you discuss here today, is not just a topic of conferences, that it is a commitment to citizens. Kenya's health sector had learned to depend on implementation obligations that were funded with external partners. To be honest, Kenya's health sector has never been short of ambition. It has also never been short of legal mandate. But there was a need for courage to move from these parallel systems to a single system that makes every resource, whether it's government, whether it's partner, whether it's private, whether it's household, visible, aligned, accountable to one plan that the citizen contracted through the Constitution to ensure that healthcare is a reality. So Taifa Care is that proof of concept that such a system can be built. And we are augmenting Taifa Care with a policy platform that enables every single citizen, every single partner, every single university, researcher, professional to participate in it. And we intend to make this sustainable, if not permanent. And therefore, I will look into some few questions that are important during this research. First and foremost is, how do we finance healthcare systems so that they are resilient? I have already mentioned the Social Health Authority, the amount of billions that we may have disbursed, the support of the hundreds of thousands, of patients that needed serious surgeries, the cancer treatments, perhaps even the millions of deliveries that have been paid for, and how these have prevented every single Kenyan to pay out of pocket. But the resilience in healthcare systems is not necessarily in the prevention of hazards. It is in the predictability, the stability of these health financing systems, so that investments can be more long-term. So that if you are going to put up hospitals, if you're going to put up medical schools, you're sure that the healthcare financing is not fickle. And you can look into the horizon 15 years, 20 years, 30 years, 40 years, and establish institutions that are assured of a genuine, efficient, stable, predictable financing engine for a healthcare system that works for the people, that aligns the value of your investments. And I believe this is the gap that we are closing with the establishment of institutions such as the Social Health Authority. And it is also the opportunity that exists for researchers, for universities, so that the discipline that we say we are bringing is matched with evidence, is matched with some level of precision that can only be documented through professionals and through institutions like universities. We want to bring government allocation. We want to bring the premium collections from employers, from citizens, and also the partners who are still working with us, whether they are working via institution to institution or government to government or co-financing arrangements or multilateral arrangements through donors, into one count, one basket, into one place that then can enable every single action in the healthcare system to be assured of sustainability. And that action includes even the action of training healthcare workers like you do, the action of research that enables your publications to become proprietary instruments, to get into innovation, to get into drug candidates, to get into manufacturing. All of these things are empty if you do not have a structured system of financing the healthcare that the citizens require. Many institutions in many countries that have moved forward have looked at resourcing as a serious structure, and that is what Kenyan government is doing. The second question really is about what are the basic issues that bedevil the citizen? What are these things that we can collect into a primary healthcare system? The Primary Healthcare Act reorganizes service delivery around community health, looking at promotion of health as a core pillar of the health system function, looking at prevention of disease as a core pillar of the healthcare system, and then looking at basic restoration of health, which includes identification of problems early. That is why we have instituted community health strategy that includes 107 community health promoters, now deployed nationally, and now equipped, and now digitally connected to every single household. This is the layer of the system closest to the citizen, and the evidence that the healthcare systems is unambiguous, and this is an investment that has paid in terms of preventable referrals and avoidable deaths. So far, we have screened more than 4.8 diabetes and taken more than 9.9 million blood pressures. The honest question is the depth of coverage at every community, but more importantly, the linkage of every single citizen to the facility. And for you as researchers, is the amount of data, the amount of collection that would save you hundreds of thousands of dollars that you spend in surveys, and the value that we can derive together if you position your research questions, if you position the training, if you position the universities to draw from this environment and the investment that the government has put in place. And because we have already thousands of contracted facilities, public, private, faith-based, this standard is available. What we need to do is to structure these partnerships and to work with you in this shared obligation of making sure that healthcare systems are resilient and that healthcare systems deliver when the citizens need them the most. The third question is, how do we build in efficiency within this resilience? The Digital Health Act establishes the Comprehensive Health Information System as the data backbone that links clinical records, financial claims, supply chain information into one architecture. There is a magic that you get by digitizing systems. There is a magic that you get by digitizing systems that removes the excess of bureaucracy, that removes the lack of visibility, but more importantly, that administers urgency, that administers time value. And every system now recognizes globally that resilience does not just mean ability to withstand shocks. Resilience also means the ability to deliver fast. And digitization is the easy part. The hard part is using that data honestly. The hard part is using that data to detect the barriers, to detect the wastage, to detect the fraud, and doing that while cross-referencing with practitioner registries, while referencing with population data, and while tracking real-time utilization, not just of services, but utilization of resources, and also utilization of the people that give the services. You can get way more from a surgeon, you can get way more from a nurse if you enable them and reduce the workload just by digitization. I have had the opportunity to be the CC leader for Nairobi for health, and just by
We seem to have lost the PS, but we give him time. Yeah, maybe a minute or so he'll be able to rejoin.
As we wait for PS Oluga to come on board, we've been sitting for a while. We can all stand and stretch for a minute, and then we sit back. We can all rise and stretch. And yes, we can use this for a very brief bathroom break very quickly. People that are sitting, it is healthy to stand after sitting for so long. So let's all stand. Yeah. And for those that are going for bathroom break, please do that quickly and come back so that we continue. Okay, we can go back on our seats. Thank you.
We are just going to be finishing this session in the next couple of minutes, and the next session is even most important. I request that we kindly sit down. We just stretch, sit down, so that we can finish. I request that those walking out, please allow us just a couple of minutes. We conclude the session. The PS will be back, but as he comes, we're setting up the panel, which is very, very important. We would like to hear from various experts in their spaces, and that's very important. And they will be picking to us. I urge us to kindly remain seated, just stretch a bit, because we've been seated for a long time, and then we conclude the session.
At this point, we are going to constitute the panel discussion that is going to be made up. We're going to have two panel discussions, and the first one is going to be made up of our Vice-Chancellors, President Wuba, Professor Kiplangat, and Professor Rotich, together with the representative PS Higher Education. So we will request you kindly to take your seats up front so that we can move into this session. Okay.
President Ruba, perhaps you can sit here.
Okay.
I understand that the PS is back. So if you can hear me, PS Oluga, you can. So PS Oluga, I understand, is back. As you wrap up, we're going to go in. Please, PS Oluga, go on, then we will go into the question-answer session. PS Oluga.
Thank you so much. I do apologize that I think you lost me, and I think that simply means I need to be quick. I'm made aware that when I was speaking about primary health care and the community health strategies and the systems that we've put in place, and how Kenya has equipped and digitally connected every single household, and forming a layer of a system that is closest to the citizen and that has the evidence from systems worldwide that nations must invest in preventable referrals and avoidable deaths further down to every single household. And I wanted to move to the third, which is basically how do we ensure that resilient healthcare systems are data-driven. Kenya has established the Digital Health Act, which has enable the comprehensive health information system as the data backbone linking clinical records, financial claims, supply chain information into one architecture and administered through an agency, the Digital Health Agency. Every healthcare system now recognized globally as resilient has discovered the same lesson, that digitization is the easy part. The hard part is using the data honestly and using the data to detect fraud and using the data to cross-reference with the practitioner and with the registries and with the populations against claims, against utilization of resources, utilization of services, real time. This is what we are doing currently. Every single evening, we get a report of mothers who have passed on because we want to reduce our maternal mortality. Every single evening, we get a report of newborns that have passed on because we want to respond real time to prevention of deaths in facilities for mothers and for newborns. The honest question is how this governance infrastructure can be done at scale to remove the same blind spots that make healthcare systems not resilient. The fourth question was, how do you produce health resilience from health products and technologies? Kenya and Africa imports roughly 70% of pharmaceutical products and merely 100% of the vaccines. Even with a financing scheme that is extremely stable, we must be sure that the healthcare systems will still be vulnerable if the medicines, the diagnostics, the devices that care depends on are sourced entirely from outside our borders. This is why we have launched the Kenya Health Products and Technologies Local Manufacturing Strategy of 2026-2030 that makes this initiative run right inside Taifa Care Reform, which is basically to say that the benefits package that we have within the Social Health Authority must be matched by a provision for health products and technologies that is manufactured here locally so that we reduce cost, we make it consistent in terms of supply, and we can be assured of the quality. We have the single most powerful demand signal from Kenyan manufacturers being offered as the data because we have established a track and trace system that looks at aggregation of consumption of every single product at the last mile in the facilities and community chemists. We have an opportunity for research to look at these systems and to convert that demand signal into bankable, multi-year research proposals that quickly can gain innovation, investments, and commitments so that healthcare systems truly become connected and truly become resilient. These are not separate work streams. They are not competing for any attention. These are one machine. Financing without primary care pays for care that never reaches the citizen. Primary care without digital visibility cannot be measured, and what cannot be measured cannot be defended. But more importantly, it then creates the blind spot for lack of accountability. So the digital health infrastructure without local manufacturing capacity is a system that knows precisely how dependent imports can remain, and that makes the system even more vulnerable when you have shockers such as COVID-19 or some war somewhere that then makes it nearly impossible to get the products that you require to deliver care to the people. So building the four pillars as one architecture makes the healthcare sustainable, makes the healthcare responsive, and makes us closer to achieve universal health coverage. And here in Kenya, we are treating them as one single implementation agenda. I want to speak about what the moment right now is asking us to do. Number one is that our research and academic community must treat the opportunity that we have availed at the national scale as the single most useful data aggregation that should scale and inspire your research thoughts, your research questions, and perhaps alter the value that we derive from our academic institutions, not just as centers where we publish papers, but as centers where we get proprietary knowledge that can get into innovation that can get into clinical, preclinical candidates, and also to clinical candidates. Number two is how we can use this ecosystem to connect research institutions that are studying primary healthcare, that are studying digital health, that are studying local manufacturing, to the problems that they intend to solve, so that we design studies that flow not just from the population to the patient, but studies that flow across board from the shilling to the product, and remove the boundaries that are there with single grants or with single departments or with single universities, so that we look at national scale. And this is why the Kenyan government has also established a state department for research, innovation, and science. And number three, that institutions and the professions in this room come forward as partners in resource mapping, so that we have one disciplined basket, not just for research, but for the healthcare system that is implemented and counted once visibly in this one national system. I want to thank you so much for convening this research, and I want to close by the single question that I began with. When a citizen is sick, when they are frightened, and when they have nowhere else to turn to, does the system hold? Today, we can say that Kenyan system is in progress. Kenyan system is maturing. We've not arrived the destination that we intend to, but we are clear that we are on that path to achieving the objectives that every single citizen has obligated to the government in the Constitution of Kenya in Article 43. Every single day, at least 31 million people have the ability to say, I am part of this progress. We as a government are working to bring in the other third of the Kenyans. Africa carries this disproportionate share of world's disease burden, and Kenya is not left behind. So we know from firsthand that beyond the financing, beyond the digitization, beyond the supply chain investments, what is most important is that these investments deliver to reduce this disproportionate share of the world's disease burden. But we do so in this global space where we also have a responsibility to respond to global health. These questions require that we put our minds together, that for the next several years, we can derive the most value from universities such as Kabarak. We can derive the most value from institution to institution partnerships. We can derive the most value from global health initiatives. We can derive the most value from country-level partnerships, whether they are bilateral or multilateral, and determine whether healthcare systems built for citizens all over the world truly become resilient. That is the success that we all intend to have for this continent, for the world. And the search continues. That search includes research. And the assignment, therefore, is for you to match the evidence, first to produce that evidence so that we are not just aspirational, but we are clear that the evidence will meet the aspiration of the people. That's the standard that we are asking this room to set up. Thank you so much, and I wish you very great deliberations in this conference. May God bless you. Please enjoy Kenya. And the government of Kenya, the Ministry of Health, is fully committed to support institutions such as Kabarak. We are keen on improving the quality of training. We are now looking at, in the era of digitization and AI, how to look at medical training differently so that we deliver quality healthcare, in-service training, use simulation-based trainings so that we match the interventions that we have with the correct quality, the correct experience that our citizens expect from our healthcare systems. Thank you so much, and be blessed.
Thank you very much, Dr. Ouma Oluga, for that inspiring talk. I hope you can listen to me. If you can hear me, we would like to appreciate you by giving you 3 Nyayo claps. That is going to be what we are going to do the whole day. 1, 2, 3, funga, fungua. So thank you very much, PS, for State Department of Medical Services, because Kabarak University recognizes the support the ministry gives the university, especially in terms of internship for all our trainees in the School of Medicine and Health Sciences. And I would like also to assure the ministry and the government that Kabarak University is committed to producing competent medical practitioners for the highest common good of humanity. Thank you very much, and God bless you.
Thank you very much, Mr. Vice-Chancellor, sir, for this time. And we are going to kickstart this panel discussion. My name is Mercy Singoe. I teach human anatomy from School of Medicine and Health Sciences. I'll also request my co-panel chair to introduce himself.
And my name is Michael Walehwa. I teach medical immunology at the School of Medicine and Health Sciences.
Thank you. We are going to ask questions to each panel member, 1 question per the panel members, and then we are going to ask the audience to also ask a maximum of 4 questions that will be addressed to each panel chair. And we also request PS, Dr. Ouma Oluga, if you can remain until, because he's part of this panelists, because you also have some questions for him.
We request that we keep our questions very brief and even responses so that we can save on time.
Thank you very much. And so, Antula Kipe University Professor Joseph Totich. Our question is, Kenya is actively pursuing universal health coverage. What innovations or reforms do you believe will have the greatest impact in improving equitable access to quality healthcare?
Thank you. Thank you very much, and good morning, everybody. Yeah, is it afternoon? My apologies. This is a question which is really very, very important for this conference. First, the universal healthcare coverage in Kenya is an innovation in itself because it has never been done before in Kenya. And this is a system whereby everybody in the whole republic will have access to medical care, which is different from what used to happen before. The important thing here is that this universal health coverage is a joint effort which is done by everybody, either employed, non-employed, as long as you are involved in some business or some income generating activities, you contribute to this kitty that will support the other Kenyans in getting healthcare. Now, the thing that we need to do as Kenya is that it would be a good idea to identify the most vulnerable or the most needy of our population so that we can put more resources there and to assist them to have a better health than they are now. And the reason is that they might not have the capacity to pay for expensive medical care. So the government needs to identify them in some form and provide resources to ensure that these people get health care. The other thing that I would like as an innovation that needs to be taken is that in order to improve health of the community is to take care of what we call the child health care, like the immunization, which of course will do a lot of prevention of primary diseases. The other thing that I think needs to be done is a preventive method and promotive health services, whereby people are encouraged to avoid certain situations or hazardous situations which will aggravate their health status. Especially non-communicable diseases, we know that this non-communicable diseases is increasing, especially in Kenya and third world countries. And this is as a result of maybe not knowing what needs to be done to avoid them, like smoking, drinking of alcohol, engaging themselves in activities that are extremely hazardous, that will increase diseases like cancers, diabetes, hypertension, and things like that. I'm not leaving out also communicable diseases because communicable diseases can be easily prevented, and if we can put resources in this, then we shall spend very little money in dealing with other critical health care. Lastly, Kenya already has a team of people who are providing health, or what we call primary health care. These people also need to be facilitated and given further training to handle other diseases or other conditions that can be dealt with on the ground before they reach the hospital. Lastly, in order to give better health care, it is better for us to use evidence-based management of diseases or management of patients in our hospitals and also outside of the hospital. That is it for now, but I would like to encourage that primary health care is more important than tertiary health care. Thank you.
Thank you.
Thank you so much, sir. I have the next question that I would direct to Dr. Caroline Hunja, the rep for the PS Higher Education. What role does research and innovation funding play in enabling multisectoral action for resilient health systems? I don't know if you got me clearly or I repeat. Thank you.
Yes, thank you very much for that question. I'm going to deal with that question by looking at only two aspects. It's quite a broad topic because, you know, research and innovation is at the heart of all that we do. But various areas of emphasis, which I feel are very, very important, and of course our PS Health has also touched on that. One of them is the importance of collaboration. Now, when we talk of collaboration in research and innovation specifically, one of the things as a State Department we've always encouraged is when we talk about collaboration, let different experts collaborate. We talk about STEM, yet we rarely touch on the role of humanities and social sciences. It's very difficult to carry out research for humanity when you don't deal with the social and humanities aspect of human beings. When you carry out research, it should ensure that it encompasses all aspects of the social sciences, the culture, the way of living. Let that be part of the research that we're dealing with, such that the findings that we get can be easily adopted by the people that we're developing solutions for. Otherwise, when we leave out that particular important aspect, then we're developing research so it can remain in our shelves, which is not, quite prudent. Now, when we also talk about collaboration, we've been encouraging that you collaborate with industries. Researchers should also collaborate with industries so that the gaps that are in existence can be identified from both ends, not just in our societies, within our people, but also the industries that are supposed to produce products. And these products are supposed to be taken up by the same people that we are researching for. And so it becomes multidisciplinary, becomes multisectoral, and that brings in a very important way of dealing with this. We nowadays call it One Health approach, and that is indeed something we need to start thinking of very seriously. The second thing I want to look at is the importance of data. Many times we produce massive amounts of data, but then how much does the data we produce inform the policies that we develop, inform the kind of innovations that we develop, inform the products that we develop? We have a lot of data. How much are we using that data so that it can help us come up with solutions? It is through that, because when we deal with data, we're looking at a long-term effect that is ongoing, and that long-term study is able to now help us adapt to the changes that are continuously happening, help us predict the future through very important models, such that through these models we are able to know what could happen. How do the global dynamics of even universal health coverage of disease, how are they shifting? And so it is very important we stab at this problem, making it multisectoral, looking at collaborations and partnerships, collaborating with industry, collaborating with each other, ensuring that we are interdisciplinary, and finally ensuring that we give data the importance that it deserves. Thank you.
Thank you very much. And so, Professor Uba, innovation is central to this conference theme. How can universities ensure that scientific innovation translates into equitable healthcare impact rather than remaining within the academic institutions?
Okay, the question about how the research being done at the universities, can be used beyond the universities starts with the fundamental purpose of the university. As I mentioned yesterday, the university should consider themselves to be part of the community. So if you are part of the community, then whatever you do should have an impact on the community. We often talk about community engagement. This is a situation where, for example, back home, students in various programs, our nursing program is an example, they actually get opportunities to work in the community. They go with faculty members to hold clinics, to do screenings, and in that case, these students, whatever knowledge they are acquiring, will not only be theoretical, but also will have an impact on the community. So it starts from the mission approach of universities. We often tend to think about the reputation of the institution being ranked number 1 or number 2. at the end of the day, that means nothing if the university is not helping people in its community. And that's why I keep talking about in Africa, the issue has become we want to be ranked or we want to do something with the help of someone from outside. I think within our own local communities, we have enough problems that as faculty members, if one of your goals in your curriculum, in your course, I threw a challenge yesterday to Kabarak University faculty and students. Monday morning, identify one problem in Kabarak or in Nakuru. And you as a faculty member, how will you work with your students to address that problem? If we have that mindset, then whatever we do as a university will be done in terms of helping our community. And I think that is key. The last part of it is faculty evaluation. And I know we have faculty members here. Let's ask our faculty members when they are evaluating each other and we are looking at their research work, do we ask ourselves that how did this research improve the lives of other people? Okay. It's a very simple question. If we know it is one of the criteria that will be used to evaluate faculty members, then they will design courses that will help the community. And it's a win-win situation in that case.
Thank you so much, sir. Let's appreciate it. And the next question goes to the VC Kabarak University. And the question is, what role should private universities play in accelerating equitable healthcare innovation for underserved populations?
Right, thank you very much for that question. Private universities in this country and in the world definitely have a role to play in accelerating equitable healthcare innovation for underserved populations. So I will use the case of Kabarak University. As a private university, we have a unique opportunity to serve as agile innovation hubs. The turnaround of our processes is quite fast because we don't have the red tape. We can rapidly carry out pilot studies and scale innovations in diagnostics, in digital healthcare delivery. We can also quickly pilot and scale innovations in mobile health applications that can be moved from one place to another. And also, we can easily pilot and scale innovations in community-centered service models. And this university has done that. I don't have the luxury of time. I would have given you illustrations, but that is what universities can do. Furthermore, private universities can also accelerate equitable healthcare innovation for underserved populations by building strong collaborations with government. The case of Kabarak University, for example, we have collaborations with several statutory organizations. You know very well that the medical and health science programs are regulated by the statutory organizations. Kabarak University is 100% compliant. Every program that is being offered in this university has been approved by the relevant statutory body and also by the Commission for University Education. Kabarak University has also collaborated with industry. The School of Medicine and Health Sciences has collaborated with many mission hospitals in this country. We have operational MOUs with hospitals such as Kijabe, Tenwek, Kapsawar, even Machakos Referral Hospital. We have E10 Referral Hospital, Baringo, and so on and so forth. Of course, not to forget the Nakuru Referral Level 5 Hospital. The School of Pharmacy also has several collaborations with pharmaceutical companies, locally and internationally. Kabarak University has also built strong collaborations with communities in different parts of this country. We can, as private universities, also generate affordable solutions that are tailored to underserved populations. Currently, Kabarak University innovators in the School of Medicine and Health Sciences are working on what we call a Mama's Hub. That is a software that can be used for healthcare. It can be moved from location to another, particularly in the underserved populations. That is some work in progress. And it is my hope that it is going to be, it will move from research all the way to commercialization. It has already been, it has an IP now, and it has been copyrighted, and I think the other process is going on. And that will be affordable, and that will be useful for the underserved populations. Private universities also can play a very, very key role in supporting translational research that moves discoveries from the laboratories in our institutions into real clinical settings in hospitals. And finally, private universities should bridge the gap between innovation and equitable implementation in order for healthcare advances to reach vulnerable communities. So that is the role of the private universities. And it is therefore important for the private universities to be supported by government 100% to ensure that they deliver on the mandate for the good of society. Thank you very much.
Thank you, sir. A round of applause for our VC. And now a question for the last panelist on this panel, Dr. Omar Oluga. Dr. if you can confirm that you can hear me, please. Dr. Omar Oluga, can you hear me? Do we still have the PS with us? Apparently he's dropped. So those were wonderful responses from our discussants. We would like to now entertain up to 4 questions, 1 question for each panelist from the audience. I would like to request that you keep your question very brief and concise. So you say your name, the panelist to which you are directing the question. I request that if a panelist has already been asked a question, please don't direct another question to them, so that at least we have a question for each. We keep that very brief, so that I can see Dr. Doris over there. I can see Dorcas Gathoni over there. Those are 2 questions. If someone can move the mic. I can see Professor from JKUAT over there. And I can see Dr. Sam Longo over there. So those are 4 questions.
Thank you. My name is Dr. Doris. I'm a midwife, and I'm a faculty member. My question goes to Professor Uba. Your presentation was very enticing, and what captured me was you talked about how the private sector needs to be anchored into the national priorities. A brief story, I come from a county where mothers who are pregnant would come to the ANC clinic, and after that, within some few hours, they would go to a woman in the village called a traditional birth attendant. I keep wondering, what is this that they get extra there? So I want you to kindly suggest how we can anchor the TBAs and the herbalists into the national priorities, because they also contribute to this agenda of resilience by design. Thank you.
Thank you, Doris. Thank you. Next question. There is Dorcas. Dorcas. Oh, yeah, proceed.
Thank you very much. My name is Dr. Musa Mohammed. I'm from JKUAT. I'm the partnership coordinator. When I look at you, I look at JKUAT, and for sure. Thank you. My question goes to Professor Kiplangat. First of all, Kabarak University actually is a story to tell, a very good university. All the good things about university is being mentioned about Kabarak. With this era of the economy, the donor fundings, how have you sustained and managed to pull through? And my other question to you is, from research to policy to patent, as Kabarak University, where are you? I can't live by saying something to my colleague, although now in the State Department. Partnerships, where do you link us in terms of these foreign partnerships, especially the universities? Thank you.
Thank you. Allow us to. Thank you. Dorcas over here.
My name is Dorcas Gadoni from the School of Pharmacy, Pharmaceutical Microbiology Lab, and my question goes to Dr. Carol. In your view, what are the measurable indicators that should be used to assess whether a healthcare system is truly resilient, and how can these indicators guide policy and investment decisions?
Thank you, Dorcas. Please come again. Please repeat the question.
The measurable indicators that can be used to assess whether a healthcare system is truly resilient, and how can these indicators guide policy and investment decisions?
Thank you so much. And the last question now, Dr. Sam Longo.
Thank you very much. My name is Sam Mulongo. I'm the chair for the Department of Nursing at Kabarak. My question goes to Dr. Carol. Dr. Hunja.
Okay. Dr. Sam must have missed the instructions.
My question goes to the PS education.
Okay, you may proceed.
So while artificial intelligence offers significant benefits for learning, a blanket or uncritical adoption across higher education risks diminishing students' capacity for independent thinking and problem solving. What would be your recommendation for institutions of higher learning to balance between integration of AI and the development of critical thinking skills?
Thank you, Sam. So one more question. And the panelist remaining is the VC Laikipia University. Yes.
Hello. Thank you so much, the VC of Laikipia University. This is my question to you. It is still augmented with the issue of biopiracy, and by extension, it might touch on Professor Uba. And my question is, yes, as Africa, we are ready to do a lot of work in terms of innovation here in Kenya. But now, we are the source of raw bioassays for international entities. So you find we may not have all the platforms required to do analysis of maybe the drugs we have discovered. And hence, we may have to source these services. And because of that, we have become frequent victims of biopiracy and also uncompensated data exploitation because of what we get, and then we send out there for analysis. And then you find maybe our maybe design or our hypothesis was not sufficient, and people take advantage of this. So how do we patent, protect our data as Kabarak per se? We get a very good formulation that can be used in pharmaceutics. How do we protect ourselves as we try to do these things locally? Thank you.
Thank you so much. And now we have received questions for each discussant. I would like us to follow the same. That question was for the VC Laikipia University, but she extended it to Prof. Uba, so we can allow both of them to speak to it. But we now start with the VC Laikipia, then we follow the same order. The questions were asked. Please proceed, sir. Yes, yes.
Yeah, there was no question for me, basically. However, because I was very clear and straight to the point. Now, the one I would like to encourage ourselves as researchers and also university fraternity is that if you have any innovation, please ensure it is patented through the IP, intellectual property, which we have here in Kenya. So, and protect it as much as you can until it is patented. Then from there, you can now market it for commercialization and things like that. Otherwise, if you don't do that, then all of it will be a waste of your time. I think that's all I could say in that respect.
Thank you, sir.
Professor.
So we now let Prof. Uba to speak to it, if there's anything in response to that question.
Okay.
Yeah.
So, do you want me to talk about the biopiracy first?
Yes.
Okay. I think the issue comes down to our own perception and our own culture about what we invent here and the innovations that we do here. Okay. I'm going to use an example. If growing up, okay, almost every cloth that I wear was sewn, okay, we didn't buy it online or we didn't buy it at a store. My mom was a seamstress. Okay. I didn't really know the value of that till I went to the United States and I realized that I can go to the store and buy a shirt for about $25. If I wanted it sewn, to about $100. The customization of it. But I never even value that. That is the problem we have in Africa. We often don't realize or put as much value into what we bring to the table. And I think on the issue of biopiracy, an example that I have, I ran a summer research program at the University of Cape Coast for 14 years, funded by the National Science Foundation. In the first couple of years, the students published mainly in Western journals. Then in the third year, we said, we're doing all this work in Africa, but why aren't we publishing in African journals? Okay. The first response by some of the faculty members who supervise the students was that, well, they are not prestigious. Okay. Now, think about it. There's a ranking system for journals. How do the African journals compete in these ranking systems? We have to demonstrate that a lot of original research can be done in Africa and can be published in those journals. That then would help us to avoid publishing in areas that potentially will lead to, basically losing, that's the proprietary power of our work. And I do agree. How many universities in Kenya have an IP office, intellectual property office? Even in the US, not that many universities have them. So with Kabarak, since the goal is to start research that can potentially be commercialized, it will be helpful to already start thinking about having an IP office on this campus so that all the original work that is being done, you can apply for the intellectual property rights to them so that if someone uses your knowledge or your ideas, you can challenge it. Until you have the IP, you cannot challenge somebody taking your knowledge and applying or commercializing it. So that's very important. And I know this by first experience because at Virginia Tech, I was there when they set up the IP office. And prior to that, the engineering faculty will come up with all these top discoveries. And we see, venture capitalists fly out of Silicon Valley, come to Virginia Tech, and they go away with the knowledge. And the university said, nope, we should find a way to actually have an IP office and they can come and buy the IP at a higher rate. We should be thinking that way in Africa. So if Kabarak can set up an IP office, that will be the first step. It will prevent some of the biopiracy. And also, as faculty do partnership or collaborative research with foreign scientists or foreign collaborators, there should be some clarity about who owns what. Okay. You collect the data from a rural village here. Okay. back in the States, people have to sign to say that you can use my data. Okay. Over here, I see scientists come in, collect data. The next thing you know, they've published it. And the people in the village, the most they will get is, we collected data from this village or this region. That's it. We need to start moving away from that. I know a university in the States that has actually worked in the community in Ghana for 30 years. They have the longitudinal data, okay, and they publish regularly on that data. This is a medical school, okay. You hardly see any credit being given to that village. What the villagers think about is, oh, they fly in, they bring us some goodies, they bring us medication, they pull our blood, and they take it with them. We can't afford to continue with that. So that would be my response to that. We have to, step up. Nobody will do it for Africa. Nobody will do it for us. We have to step up and do that. So you have to understand the game so that you can play it. So we need to have those IP, put in place. Now, the question about, can I answer quickly the first question? Because the question, I like that question about how are we going to use our traditional herbalists working with, our Western, medical or healthcare system. When you go to, that's most villages, not only villages, but culturally, when we got to a point where Africa has to really engage with the outer world, okay, the external world, there was a point where typically we considered whatever knowledge came from outside superior to ours. But we forget that before Africans interacted within the Europeans and whatever followed, we had our own systems. We had our own medical systems that we used to cure diseases. Yesterday at lunch, when we were provided with our meals, okay, the one who provided us walked us through each fruit. She explains, this is for digestion, this is for knee health, this is for blood pressure. Okay, we knew all of that, and that is called food as medicine. So bringing it back to your question, they come to your hospital or your setting, they get the initial care, the antenatal care, then they go to the local herbalists. Okay? If I were in your shoes, one of the first steps is I wouldn't even ask them. I would go to the local herbalists and find out what do they get when they come there compared to what they got from you. Okay? That would be the first conversation point. And often there may be gaps between what they get from there and then what you provide them. That is a sweet spot that then you can work collaboratively to fill that gap. The next thing you know, you are collaborating with the local herbalists. And this has actually been done in a very systematic way. Kwame Nkrumah University of Science and Technology, when you go to their College of Medicine, they actually have a whole department that focuses on local health care. That's the local healthcare practices. You can check it online, okay, where they've integrated it into their curriculum, where students have to take classes in the use of local herbs, okay, and the various approaches that they use for diseases that are cured that are not necessarily in the books. Okay. I think that's something that you can consider. But you have an opportunity. This is innovative. Go to that lady, not the patient, and ask, when they come to you, what are they looking for compared to what you provide them? That is innovation at work. The next thing you know, you are working with several patients who come to you and go to them.
Thank you, sir. Let's appreciate the President. And now, Dr. Hunja. There are two questions directed to you.
Yes, thank you. But allow me to go into your question. I loved it. The one about Professor has just talked about on how we can integrate traditional medicine and local health workers and all that. There is an Italian foundation, that's what I Googled here. It's called Ivo De Caneri Foundation. It's located in Pemba Island. Now, Pemba Island is very unique because it has 99% of its inhabitants are Islam. And so it is a very interesting model that they've used there by ensuring that they respect the cultures of the Pemba, because it's a very small island with very few inhabitants, and they deal with neglected tropical diseases, especially filariasis. Please read about how they have managed to integrate. I visited the island, and they even took us to a traditional healer, and they make it part of their medical care, a traditional healer. We went there, very interesting. So read about them. I had to stray into that because it's a very important question. Very good, yeah. Thank you. Now, back to, allow me to please start with the AI. Because that is where I have a lot of passion. Now, every time I talk about AI, the question that is usually asked stems from fear. It is possible that when we use AI, we will lose our creativity. We will lose our capacity to develop new knowledge. I always quote Albert Einstein. He said, if we knew what we were doing, we wouldn't call it research, would we? Right? Majority of the information that you find in the publications that we throw out there. I don't know how many research scientists we have here. How many have collected a publication online, collected a protocol, scientific protocol, gone and replicated it word by word, and it never works? How many? All of us. I am 100% sure. Anybody who has worked in a lab, I have experienced it numerous times. What does that tell you? As much as we collect information from AI, from the databases, scientific databases, national databases, we must ensure it is testable. The hallmark of science has not changed. The process of science will never change. We must ensure every theory out there is testable. Number one, my recommendation. Number two, integrity in the use of AI. Very essential. I leave it at that. Second question, measurable indicators, health systems, to ensure that health systems are resilient. It is not my area of specialization, but I feel a resilient health system should be able to deal with emergencies, emergency preparedness. We recently suffered a pandemic. We constantly suffer from epidemics in this country. Are our health systems resilient enough to deal with the pandemics and epidemics that will continue to plague us as long as we live on this earth? Number one. Number two, it should be a well-financed health system. That I do not need to talk more about it, because financing ensures that we have sufficient infrastructure, sufficient workforce, sufficient drugs, sufficient diagnostic kits and equipment, etc. And the last one, I am quite rogue in bringing people in Kenya, medical tourism. We are constantly going to India for medical care. When will we have a resilient health system that ensures people from India and other parts of the world come to Kenya for treatment? I rest my case. Thank you.
Thank you. Let's appreciate the rep here. And now to our Vice-Chancellor. I think there are also two questions.
Yes, there were two questions from Dr. Musa Mohammed of JKUAT. The first question was, I believe it was on how Kabarak University is managing under the prevailing economic conditions, where there is a decline in donor funding, among others. First of all, Kabarak University obtains revenue from three sources. We have, of course, tuition. And here I would like to mention that the fee charged by Kabarak University is affordable. If we compare with what other universities are charging, we are quite affordable, and we have that information openly indicated in our website. So we have tuition. And then secondly, we also have income-generating activities that are run by the university with a view to generating additional revenue to supplement the tuition revenue. We also have some funding through research grants, although that is minimal. We are not where we are supposed to be. So in terms of the income-generating activities, I know you must be asking which are these income-generating activities. We have several, ranging from our own medical facility. We have a medical center here. We have, of course, catering services, accommodation services. We have the farm. And we have also partnered with industry. Currently, we have running memorandum of understanding with 2 banks in this country, whereby we are training MSMEs, banking in those banks. And of course, the banks are the ones funding this exercise, so we generate some additional revenue from those activities. Something else, money is never enough, that I'm sure. So what we have decided as a university is to ensure that we are prudent when it comes to financial management. And all of you, of course, I know you do budgets. Budget preparation in Kabarak University is participatory. And once the budget has been approved by the council, then it is implemented. And of course, we only do some budget reviews, a maximum of 2 in the year, to just take care of unforeseen activities. But one practice that has helped us to ensure that we are prudent insofar as financial management is concerned is that when we prepare our procurement plan, we have a procurement plan for the year, and we upload that in our ERP system. And in that procurement plan, we have activities we have procurement that has to be done in the first semester, and some will be done second semester and third semester. So if any staff member comes and says, I am requisitioning for this to be done, we look at our procurement plan. If it is meant for semester 3 and you are doing it in semester 1, we'll tell you, no, we have not received the money for that, so you have to wait. And once you have exhausted, then you have to be patient enough to see whether there will be additional funding to be provided under the reviewed budget. The question number 2 is on where Kabarak University is in terms of research and movement from research to commercialization. Kabarak University is just 20 years old, and I'm not using our years of existence as an excuse for mediocrity. But we have undertaken a review on where we are in terms of the spectrum of moving from research to commercialization. And in a scale of 1 to 5, Kabarak University is at level 2. We are almost getting to level 3. I don't know where JKUAT is, but I will talk to you after this meeting. You'll tell me where you are. But Kabarak University has made an intentional decision to be an entrepreneurial university. And you can only be an entrepreneurial university if you mainstream research, innovation, and move up to commercialization. And to confirm that we are intentional in that, I am a member of the National Educational, National Entrepreneurial Institutions Leaders. I am a member. And I have been trained by Kenya National Innovation Agency. My DVC, Professor Ochola, has been trained because I wanted him to be converted so that he supports me. We have also trained an institutional working group led by Dr. Nyawere and two other people. And we have trained all our students and all our staff in terms of innovation. So we want to do, serious mindset change so that we move from just doing research for the sake of research to doing research which can actually solve societal problems. And we are even telling our postgraduate students, whatever research you do, that research must not just end in the shelves as a journal that has been published or a book that has been written. What problem is it solving? Can you commercialize it? So that is what we're doing. And we have also been deliberate in doing benchmarking with institutions that have done well in terms of moving their research to commercialization stage within the country and outside the country. In April, I had the opportunity of visiting 3 universities in South Africa together with 11 colleagues from various universities in this country. We visited University of Johannesburg, University of Witwatersrand, and University of Pretoria. And those universities are serious when it comes to commercializing their research outputs. And I'll give you an example of one of the universities I'm not going to mention. One of the universities has an annual budget of close to 3 billion Kenya shillings. In terms of dollars, you can divide that by 130, and then you can get to know the amount in terms of US dollars. But interesting, a third of that budget is obtained from tuition. A third from government support. A third from dividends and from the companies which have commercialized the innovations of the university. So even if one source is closed, they still have 2/3. They can still survive. And that is where I would like to see Kabarak University moving into the future. We have some innovations, like an electronic voting system that is working now. We have that to other universities, and they have paid us. I'm not going to tell you how much they have paid us, but we have gotten some money. And there are other innovations in the pipeline. But what I want to say is we are not where we should be, but we are determined and we are making steps in the right direction. Thank you very much. God bless you.
Thank you. Thank you so much. Thank you, sir. I would like us to offer a better round of applause to our panelists. Asante sana. Thank you. I am informed that we have Professor Anzala of Kavi online, and he has a question. I think that must be a very important question. Allow me kindly give him a chance to ask his question. Prof. Anzala, if you hear me, please proceed. Is Prof. Anzala online? Yes, he is. Please, Prof, proceed if you hear me. We can't hear you if you speak.
Hello, can you hear me?
Yes, we can hear you now. Please proceed.
Yes, I didn't hear the question very well.
I have been informed that you have a question for the discussants.
Yes,
so
yes. My names are Professor Omu Anzala, the founder of Kenya AIDS Vaccine Initiative, Institute of Clinical Research at the University of Nairobi. And we engage in a lot of research, and at the same time we train healthcare professionals at the highest level, mainly at PhD and postdoc level. Now, there are two aspects to health, and there's quite been a discussion here on health issues. One is the lifespan. Second one is the health span. Now, in terms of looking at health span and lifespan, and looking at health financing, what data would we look for to inform our health financing? And I want to the panelists to just restrict themselves to the Kenyan situation, looking at lifespan and health span. What data would you look for in order to inform health financing? And I say this from the point of view is that those two things combine longevity and also morbidity. And I wish the PS for health was around, but those are the issues we are grappling from, looking at health span and the lifespan. And what data would be important to actually, from those two aspects, to inform health financing. Over to the panelists.
Thank you, sir. Thank you, Prof. And we're grateful that you are with us in this conference. I would like to, give just to Prof. Uba to go first.
Well, the question said it should be made, using the Kenyan, context. So I will share with you what I have learned or what I read about. With regards to, said lifestyle and then health lifespan, okay, I think the two go together. And it comes down to the behavioral aspects of individuals. Because if you look at, let's say, financing of health, the question becomes, what penalty does anyone who is involved in risky behaviors have to pay when they go to the hospital? At the moment, as a patient, when you go, you pay the same amount, right? But some people choose to be involved in certain risky behaviors, which I think they should be made aware that it would make it more difficult for them to get the lifespan that they choose. Smoking is an example. Smoking is choice. People become addicted to it, but they started first. And some people may know that smoking is not good for them. But it doesn't stop them from smoking because they consider that, well, maybe they know someone who lived up to 90 years, but the person smoked. So it wouldn't impact them. But I think in order to make sure that this financing system will send a message, there should be instances where people should be made aware that if you smoke and I don't smoke, and you are sick, you're going to be taking advantage of the system more than I will. And if we are paying the same premiums, it means I'm funding your risky behavior. Okay. How do we handle that as a society? I think that's something that, we have to find a way to let people know that this is a challenge for everyone. So it comes down to the issue of me versus, what's happening, impacting the community. And I think when you look at lifestyle and lifespan, they often are in one way or the other related. People live, very good lifestyle in terms of take care of their health, be involved in preventative medicine, take their medicine where they are supposed to versus, going for checkups sometimes. In most cases, they have a better chance of living longer than those who neglect that part of their, their lifestyles. So, in a way, lifestyles are linked to, lifespans depending on choices that people make. And as a society, the question is, can we control that? That'll be my answer.
Thank you, sir. Let's appreciate Prof. Dr. Hunja, would you like to go? Thank you. Professor VC from Laikipia, would you like to give it a shot? Anything to add? Thank you. And our Vice-Chancellor? Thank you.
This is aside from the questions we received, but I just want to...
No. This is Professor Anzala. We must hear from the Kenyans. We must hear from the Kenyans. They cannot run away from this.
The next...
We are living longer, colleagues. And how do we tease out lifespan and health span and link this to health finance? Kenyans cannot run away from this. I must hear from our colleagues.
The next response is going to come from a Kenyan.
You are my colleagues here. I have to put you on the spot.
The next response is going to come from the Vice-Chancellor, Kabarak University, and the Vice-Chancellor is Kenyan.
Okay, I'm sure he was talking about lifespan and he was talking about lifestyle.
Health span and lifespan.
Well, I think I would like to ask the experts in the room to respond to that question, because I would like a medical practitioner to answer that question. And we have medical practitioners in the house.
Thank you. We have...
Doctor, you want to respond? Please come. Dr. Mulongo. If you have no response, don't pretend you have the answer. Let somebody respond.
Thank you. If I get it wrong, you forgive me. Prof. Anzala, thank you for the question. I would imagine that we take a lens of, for most of the chronic diseases, we have established DALIs and CALIs. I'm sure you are aware about that. We have cancer registries and we can quantify CALIs and DALIs for most of the chronic diseases. Suppose we link CALIs and DALI outcomes to insurance coverage, for example, and we can ask the question, people who are insured, maybe have private covers, have more financing, have better CALIs and DALIs compared to people who are not insured. I would imagine that we would take that lens, Prof. Anzala, just by looking at our CALIs and DALIs. Thank you.
Thank you so much.
Exactly. That is actually the whole point here, that the data, and we talked about data this morning. I had quite a bit of discussion on data. That's where the data lies, exactly what has been said. And it is from there, then we begin to ask ourselves, from the primary level, what is this data telling us, and how does this data then inform longevity and morbidity? So I leave it there, but it is an issue that we could actually follow up and discuss, because data is available to be able to link the two and help us begin to think about health financing. Thank you very much, and this is a wonderful forum.
Thank you. Thank you, Prof. Omanzala. Let's appreciate him. Thanks, Dr. Blango.
Yeah, I think there is someone who is inspired to respond to that question again. Is another Kenyan?
Okay.
I'm also a Kenyan. My name is Dr. Mogesi. I'm a lecturer in the Department of Human Nutrition and Dietetics. That's a very important question that Professor Anzala has asked. And in the spirit of prevention of diseases, we need to think about lifestyle, lifelong perspectives. We often think about health as a happening. It's a process that starts even before the child is born. So to look at it from the lifespan perspective, thinking about basic things, being a nutritionist, of course, nutrition of the mother before she becomes pregnant. And this can give a big solution to all the problems we have. Thank you.
Colleague, sorry if I'm talking too much, but maybe just to introduce a term that I would like us to follow through as we go ahead with this workshop. There are two words, investing in health and investing in disease. When we build level 4 or level 5 or level 6 hospitals, we are investing in disease. We sit in hospitals and wait for people to get sick. How do we invest in health? And this is actually the essence of the question I'm asking. How do we invest in health and put a lot of emphasis in health, although they will be in tandem so that we are also investing in disease? So as you discussed, maybe the whole issue would be, how do we unpack the two? Investment in health and investment in disease. Okay.
Thank you, sir. A very interesting discourse. I can still see another Kenyan who wants to say something, and this is a long practicing medical doctor, Dr. Godho. I think this will be the last response to this, so that we can move.
Yes, and it is intentionally supposed to be the last. Now, it's obvious what has been stated. As an obstetrician and gynecologist, the longevity of an individual baby, as somebody has rightly said, begins from the very first day. One of the challenges that we've had in the third world countries is that mothers will come to the antenatal clinic in the third trimester. So there are conditions that arise in pregnancy that will actually be comorbidities after delivery. So, as we talk about investing in disease, can we invest in our mothers so that they start their clinics early? Because if they do start in the first trimester, there are some conditions we talk like preeclampsia or pregnancy-induced hypertension, diabetes, and all of those conditions, they can be prevented. And on a light note, that's why I give all of the mothers a sweet.
Thank you. Thank you, all of you, and thank you, our panelists. We now go to the last bit of this discussion, and this is going to be a parting shot. The parting shot, just 1 minute. In her submission, Dr. Hun just wondered when we'll ever have a resilient health system. And I thought it's good for us to speak to that just in 1 minute. Do you think this is something we are going to achieve as a continent, from where you sit and from the space you operate from? Let's start from the Vice-Chancellor like Laikipia University. Professor Rotich. Sorry, sir. Yeah. Please proceed.
You're talking about parting shot or take home?
Parting shot.
Parting shot.
Home. Yeah.
Yeah, thank you very much. My parting shot here is all of us here have some knowledge about keeping healthy and making other people healthy. I would like us to avoid eating or putting ourselves in situations which will increase our risk of being sick. And I think we can also communicate that to our local people at home, that they should take care of their health. They should institute preventive care instead of waiting to be sick and go to hospital. My mother was a herbalist, and she used to give us some concoctions. Maybe those are the things that kept us out of hospital. But what I'm asking you as intellectuals in the room is that, can you do research in those concoctions and see what elements or molecules that can be used to be improved to give better natural medicines that do not have toxins? Thank you.
Thank you. Now, Dr. Hunja.
So the question is, will we achieve resilient healthcare system? You know, we are a people of hope. We cannot in any way give up, and so let us not give up. Number two, when I look at the way universities are running with these ideas and the way universities are carrying out research in great ways, establishing partnerships, I can see that indeed we are going to eventually achieve that resilient health system. And when COVID strikes again, we will develop our own vaccines. Thank you.
Thank you. Thank you so much. We have the Kenya Biovaccine Institute, so we're heading there. Prof. Uba.
I think for any problem, one way by which you can solve it is to be able to identify the problem. We've had a lot of, challenges. We've had several issues talked about here. In terms of resilience in our healthcare system, just talking about it today is part of, our efforts to get to a solution. But it should be such that, we don't talk about it one time, forget it, wait till next year before we talk about it. It should be a priority. That's the only way we'll be able to be a resilient, continent, as you are saying, when it comes to health. And I really like the comment that was made by my esteemed colleague here that when growing up, he took a lot of concoctions. Same thing happened to me. For my grandmother, there was no disease she couldn't cure with concoctions. Whether it's topical or it's internal, she had a concoction for you. Okay. It relates back to the earlier question where I mentioned that I think universities should start bringing in herbalists, who would actually teach them something. Because in terms of the molecules, when you think about aspirin, for example, okay, aspirin came from research done from the bark of a tree. Where did this tree come from? Think about it. Our forests are loaded with a lot of, medicines that as a continent we haven't really, exploited or done research on. So if, each and every one of us here knows someone who provides these concoctions, and you know someone who is a pharmacist, or you know someone who is a chemist, we have with us here Dr. Jeremiah Mbidio, who is a chemist. Okay, let's bring the chemists on board. These would be good projects that should be funded. And I think Kabarak's focus on pharmaceutics is a very good place to start. Don't work on it only using Western medicine. Let's bring in the local herbalists. Let them partner with us. You'll be surprised the amount of new knowledge that can come out of that effort. Thank you.
Thank you. Let's appreciate Prof. And now Vice-Chancellor.
All right, thank you very much. Well, I'll make a parting shot and then make just two concluding remarks. Achievement of resilient healthcare system. It's not really a quick fix, but it is achievable. So for us to achieve a resilient healthcare system, we must make deliberate efforts to invest in training, invest in provide funding, because you need the human capital. You need men and women who are trained so that they can carry out research and come up with innovations that can help the healthcare. So we look forward, as a Kenyan, to a time when we'll have Kenya's traditional medicine, which can be sold and commercialized all over the world, just the way you have other traditional medicines elsewhere. There is a community in this region that used to operate the heads of the people, and they used traditional medicine. They could just open up and cover. That community still exists, but I am sure the traditional medicines they are using have not been identified and even further developed. So Kabarak University School of Pharmacy, you know what we have discussed, and that is the way to go. It doesn't matter how many years it takes, but we will get there.
Thank you.
You very much.
Thank you, sir. Let's appreciate our panelists. We will be there. We're not sure how long it's going to take, but we'll be there eventually.
All right, I said I want to make some two comments. Dr. Hunja, I know you are passionate about AI. I want to inform you that Daniel Arap Moi Library of Kabarak University has AI content, and we have also sufficient up-to-date electronic material that can be used by researchers on and off campus. You can try before you go, all right? And then secondly, Kabarak University is not using old teaching methods. You talked about old teaching methods. For us, we moved away from old teaching methods from the year 2018 when we established the Directorate for Excellence in Learning and Teaching, and we're doing our own in-house training of staff in the 21st century skills. And we were privileged to have a team from Millersville University in 2023 who carried out a training program for all our academic staff for 1 month. Thank you very much. That's a good story, isn't it?
What an engaging session that we've had. And I would want us to appreciate these panelists the way we do it in Kabarak. I think by now we all know how we do it. And so I want you to warm your hands. And we are going to give them 4 heavy Nyayo claps. Let's go. Moja, mbili, tatu, nne, funga, fungua. And so, our time is fast spent, but I'm sure all of us have gained something from the presentations that have happened since 8 a.m. in the morning. And our Vice-Chancellor, sir, you will appreciate our guests by giving them a token of appreciation. And once you get your token of appreciation, I'll ask you to stay up front because there is a photo session that will follow, and then I'll give the next directives. Vice-Chancellor, sir, the first person you'll appreciate is Professor Rotich. Yes, sir. The second is Dr. Hunja on behalf of Dr. Inyangala. The third is President Wuba. Okay, thank you, sir. Our time is fast spent. We needed to have another panel discussion, but you'll all agree with me that we've been sitting and you're hungry. So I want to thank the panelists that are to come for this second batch for your willingness to come and participate. But I'm also sure that the vice-chancellors here have represented your vice-chancellors from the various institutions that you've come from. And so we extend our gratitude for your willingness to come, join us, and even participate as a panelist. And we have gifts for you too, and I'll ask you to come for the gifts as I call out your name, and then you remain up front because we're going to take a picture together. So the first panelist that would have been here is Professor Melby. Mrs. Melby, you can come in on his behalf. Our Vice-Chancellor, again, I'll request you to present this gift. The second, sorry. The second person representing Vice-Chancellor Tharaka, Dr. Lucy Kenani. The next. Thank you. The next is Dr. Raphael Namwaru, representing Prof. Olo Abudo, Masai Mara University. He's coming. Then we have Dr. Kioko Mwania, representing Professor Andala, NRF CEO. And then we have Dr. David Kimutai Meli, representing Professor Charles Mutai from Bomet University. I'll now ask our two first ladies to come up front and join this group together with Professor Ochola and our acting provost, so that we can all be arranged and take a picture.